who have been consistently with us for this wonderful academic program, what we are doing from NNF Karnataka State Chapter. So today, we will be starting our neonatal respiratory chapter. So this entire week will go through, will take you through the various common neonatal respiratory conditions and the ventilatory management, which includes conventional ventilation from basic to advanced, high frequency to volume guarantee. So I request all of you to connect to us the way you have connected from the past. So today we have got two speakers, Dr. AJAY S K and Dr. ANITA Naiman GOWDAR. So I request Dr. Guru Prasad sir to introduce Dr. AJAY S K to the audience participants, and I request Dr. Ajay to start the session after Guru Prasad sir introduces our speaker. And today's session will be moderated by Dr. Vijay Kulkarni sir. Welcome to you, sir, as well. Over to you, Guru sir.
Yeah, good evening, Prashant and Dinakar, and Dr. Koturesh, Dr. Vijay Kulkarni, and all the office bearers of NNF. It's always a pleasure watching this webinar series of NNF. I have attended from all the other organizations and bodies. Probably the quality deliberations are held by the NNF Karnataka State Chapter. If you look at the program that is charted out, it is almost in par with or even more than the DM training program curriculum. I should congratulate Dinakar and Prashant to really having put your heart into choosing the topics and the speakers. Without wasting much time, I am very happy that both speakers today, Dr. AJAY S K and Dr. ANITA Naiman GOWDAR, both of them are alumni of JJM Medical College during their MD Pediatrics. No doubt they had their training subsequently in neonatology elsewhere. And Dr. Ajay, after finishing his MD from Davangere, completed successfully his DNB training also. And he is working tirelessly, selflessly for the betterment of the poor in the city of Bellary. And he is the right person because he has traveled through time when neonatology had not really much advanced. And over time, he has learned and a lot of things out of his personal experience. So it's a pleasure inviting Dr. Vijay to speak on an important emergency that we face in our day-to-day NSU setup. Dr. Ajay, it's pleasure introducing you to the forum. Please start your lecture.
Yes, thank you so much, Guru Prasad sir, for the wonderful introduction. And am I audible?
Yeah, you're audible. Very clear, very clear.
Yeah, namaste and good evening to everybody. Before I start my presentation, I would like to tell about myself. I'm a pediatrician. I run a small newborn setup in Bellary. I've been running this newborn unit for the last 10 years and an NNMF member for the last 20 years now. And first of all, I would like to thank the President, Secretary and Treasurer of Karnataka NNF for giving me this wonderful opportunity. I've been asked to cover two topics today, pulmonary air leaks in newborn, and the second topic is on pulmonary hemorrhage. These two topics are a bit lengthy. Pardon me if I take a little longer time, the allotted 45 to 50 minutes to cover these topics. Let's start with the pulmonary air leaks first. Sorry, the screen is not moving.
There is on the lower left corner, this arrow mark. You can just click over there. Yeah. You can press that. Yes.
Right. So pulmonary air leaks is one of the common neonatal emergencies which we encounter in our newborn units. Air leaks occur when air escapes from the lung into the alveolar spaces where it is not normally present. Every newborn caregiver, be it a doctor, nurse, or a helper in the newborn unit, even the staff in the labor room should be aware of and have some knowledge about air leaks occurring in units. It's also the duty of the pediatrician and neonatal consultant to keep discussing about air leaks in babies with the nurses and others working in the newborn unit. By taking prompt actions, we can prevent complications like intraventricular hemorrhages and BPD in the premature infants, and also in preventing long-term neurodevelopmental comorbidities in babies. I've constructed few case scenarios which are frequently encountered in newborn units. For case number one, a woman of 40-week gestation in the labor room delivers vaginally. Just prior to the delivery, there was fetal desiccations were noted, and she has had a premature rupture of membranes and with a thick meconium stained amniotic fluid. The baby came out limp, active resuscitation required, and positive pressure ventilation was needed. This 3.5 kg baby boy at 1 hour of age and NICU on head boss oxygen had a worsening respiratory distress with an ABG showing respiratory acidosis. In such a situation, we normally think of perinatal asphyxia, meconium aspiration leading to respiratory distress and respiratory acidosis. We usually tend to ask our nursing staff, let's intubate, arrange for intubation and ventilation. But we need to step back a little and do a proper examination of the baby. Auscultation is the key here. When we auscultate, it's possible that we may have a decreased left sound, breath sounds on one side, and this tells a different story altogether. And transillumination probably confirms. So instead of, we may need to put a chest tube instead of intubation. And going to the second case scenario, this is a 1,600 gram baby girl got admitted in the NICU immediately after birth. She had respiratory distress. She was immediately put on bubble nasal CPAP. Initially, she was on CPAP pressure of 5 with a FiO2 of 0.4. 1.5 hours later, she needed CPAP pressure of 8 centimeter with an increasingly work of breathing. At 2 hours of her age, she was intubated and natural surfactant was in the recommended doses was given to the baby. 1 hour later after surfactant, the baby was found to be cyanotic. She is known to be vigorously having respiratory distress with increasing intercostal indrawing and sternal traction. A transillumination was done. Here, a previous intervention of a decreased CPAP pressure was required, which was not done. And a third case scenario, 1,600 gram female girl delivered prespirately at 31 weeks of gestation. Mother had not received antenatal steroid. After birth, the baby was found to have respiratory distress. She was shifted to NICU of a different hospital. And there in that hospital, she was connected to bubble CPAP immediately after admission, and chest X-ray showed RDS. The therapy was offered, a patient attendance refused. Many times such scenarios may not happen in places like Bangalore. It happens very frequently in places like Ballari and other smaller towns and cities. 2 hours later, the baby had to be intubated and mechanically ventilated. And at 30 hours of age, if with an FiO2 of 0.6, pressures of 25.5, the BG was fairly okay, acceptable ABG. But gradually over the next 6 hours, clinically not much change, but the baby needed a higher FiO2, higher PIP to maintain a SpO2 of 90. A chest X-ray was taken. So probably the chest X-ray taken revealed air leak. Probably a timely intervention, maybe this may be if the mother had received antenatal steroids or a surfactant therapy may have prevented these air leaks from occurring. So these case scenarios tell us the proper knowledge about air leaks in newborn and also knowing about what are the risks, high risk situations when these occur and what steps one need to take to prevent these air leaks. All these go a long way in saving these babies from having morbidities and mortalities. So the common air leaks include pneumothorax, pneumomediastinum, pneumopericardium, pulmonary interstitial emphysema. We'll cover all these 4 topics in a little greater detail in the next 30 minutes. And we'll also touch upon the less commonly involved common air leak syndromes. The incidence, coming to the incidence of air leaks, the incidence also varies according to the type and severity of the disease, gestational age, more premature, more chances of air leaks occurring. The incidence also depends on the mode of therapy and also depends on the expertise of the personnel. About spontaneous pneumothorax, it can occur in 1 to 2 live births who have normal lungs. But most of the time, pulmonary air leaks occur in diseased lungs. It increases when any of the positive pressures are given to the baby with a diseased lung. It may also occur during resuscitation at birth when using or when we are using high flows or CPAPs or nasal IPPVV, or in those having conventional mechanical ventilation. However, of late, especially in the last 2 decades, the incidence of air leaks has come down with the advent of antenatal steroids, new therapies like surfactant therapy for RDS, newer modes of ventilation. We have synchronized IMV, assist control modes, pressure supports ventilation. All these have decreased the incidence of air leaks in the newborn units everywhere. I remember as a postgraduate student in the mid-1990s, we did not have a synchronized IMV ventilators then, and air leaks were very common occurrence, more so if the baby were not to be paralyzed. Coming to the pathophysiology, main reason of air leaks is, if it is a spontaneous, it is because of the pressure generation, a very high negative intrathoracic pressure generation when the baby is born at birth. And in other situations, mainly because of the positive pressures occurring due to intraalveolar pressure, which causes increase in inhalation, insufflation, retention of large volumes of air. The resultant pressure gradient all causes alveolar rupture at the bases overlying in the capillaries. We take all this pathophysiology of each of these components of air leaks individually when we discuss in a little greater detail individually. Coming to the risk factors for air leaks, I'll be repeating this again and again. The common denominator for all leaks is the barotrauma. If the baby is on mechanical ventilation, the risk increases enormously, more so if the baby is needing high inspiratory pressures, a PIP or PIP or both, or a large tidal volume, long inspiratory time. And most of these happens in babies who have underlying problems. Babies with RDS in preterm, they have atelectatic alveoli, may cause uneven ventilation, and this can cause distension of the areas of the lung to receive high pressures. Babies with Meconium aspiration, Dr. ANITA will be talking in detail more about it. They have small mucus plugs in the airway, may cause gas trapping, and because of the ball valve effect, they go on to have air leaks. Air leaks can also happen in babies with pulmonary hypoplasia. Here it can be more often bilateral. If air leaks occur in both lungs, also too, we need to think of pulmonary hypoplasia. Air leaks are more common in babies with pneumonia, congenital diaphragmatic hernias, babies with transient tachypnea of the newborns. So we'll go to the first air leak, that is pneumothorax. And this is the commonest air leak syndrome. And this refers to the presence of air between the visceral and parietal pleura. And pneumothorax develops when air from the ruptured alveolus. Pneumothorax develops when air from the ruptured alveolus dissects up the vascular sheath into the mediastinum. From there, it enters the pleural space. And if the leak is large, it can produce tension pneumothorax. This is especially seen in babies receiving positive pressures. And this tension pneumothorax causes increase in intrapleural pressure and subsequently lung collapse. This tension pneumothorax obstructs the venous return to the heart. All these lead to severe hypoxia, hypocarbia, even circulatory collapse, and this can be really, really life-threatening. If it develops in premature babies, it can cause intraventricular hemorrhage, may lead to BPDs in premature babies, and later in life, neuromorbidity as well. So we need to try and avoid all babies, more so in premature babies. They should not go in for any pneumothorax as such. Coming to how exactly pneumothorax presents in a non-ventilated babies, tachypnea, retraction, grunt, cyanosis. There may be decreased breath sounds on the affected sides, and there may be features of shift of mediastinum to the other side. And in ventilated babies, the titration respiratory distress may be subtle or it may be sudden. If it is subtle, there may be slow changes in oxygenation or ventilation and changes in compliance with blood gases showing carbon dioxide retention and hypoxemia. It also can present as a sudden deterioration on ventilation. If the baby is on ventilator, sudden deterioration, usually we think of a tube block or a displaced ET tube or a ventilator malfunction. In addition to that, we need to think of air leak as well, possibly near tension pneumothorax. So how do we diagnose it? Most important, we need to diagnose pneumothorax very early before it creates havoc. For this, we need to have a very high degree of suspicion. In what babies we need to have high degree of suspicion? Babies who needed bag and mask ventilation, babies with Meconium aspirations, babies with congenital diaphragmatic amnias, babies with suspected pulmonary hypoplasia, and babies on positive pressures, especially needing very high pressures on ventilators. Another important thing is if the baby is on ventilator and when they show on X-ray to have other air leaks like pulmonary interstitial emphysema or a pneumomediastinum, we need to be very alert and extremely careful with our pressures, as these two conditions could be a precursor to pneumothorax. So how do we diagnose it? Auscultation. Many times stethoscope is good enough. With a decreased bedside on one side, we can think of pneumothorax, or by translumination. Translumination is another way of diagnosing pneumothorax. Having a cold light source, it's very, very handy instrument at the bedside. Every unit should have. It provides a high intensity fiber optic light. We need to make the room dark. Hold the probe on the affected side of the chest. The air pocket lights up the entire hemothorax. Once we see the pneumothorax, we should not wait for a chest X-ray confirmation. We have to go ahead and put a needle, aspirate, especially if the baby is unstable. Also, translumination is very useful in babies who are suspected to have who are high risk of developing pneumothorax. It's better to do a serial translumination and pick up pneumothorax very early before it creates into a bigger tension pneumothorax. This is a baby having a right-sided pneumothorax. We can compare with the other side for reference. And the next modality is, of course, the chest X-ray. It's very essential. In pneumothorax, it reveals air in the pleural cavity, and if the pneumothorax is large, there may be flattening of the diaphragm on one side with mediastinal shift to the opposite side. Smaller pneumothoraces may be missed in the supine. We need to take a lateral X-rays. Ultrasound is another very important modality. This is a very important equipment in the NICU. Apart from its use in diagnosing conditions like intraventricular hemorrhage, its use in cardiac ultrasound for diagnosing abdominal condition. It's been increasingly used for diagnosing severe lung conditions as well. And we need to go for it if there is a strong suspicion of air leak. When X-rays are getting delayed, sensitivity is reported to be around 80 to 100%, and specificity is 90 to 100%. And one study published in 2016 states lung ultrasound is as reliable as chest X-ray and is supposed to be more accurate than transillumination for diagnosing pneumothorax in newborns. This is the X-ray of a baby from our unit who we were ventilating in our hospital at Bellary, and the baby developed pneumothorax. It's a very obvious X-ray, very easy to pick up a pneumothorax here. You can see the lateral visceral pleura margin here and the inferior pleural margin. You can see some herniation of the right mediastinal pleura to the other side. And many times these X-rays to pick up pneumothorax is not going to be so easy. This is a baby with pneumothorax on both sides. Here we see a subpulmonic pneumothorax, here collection of air, and also here on the right margin of the heart, we see a thin line of air on this side, and with a very sharp cardiac margin. This suggests there is some lots of air collection in the right thoracic cavity. And on the left side, we have a obvious pneumothorax here. And we can see here too, there is a sharp cardiac margin on the left side. And also the left thymic lobe margin also can be seen. Here, the left thymic lobe is a bit compressed here. So this is a case where we have pneumothorax on both sides. This is another case, baby having pneumothorax. Right side, it's very obvious. What about on the left side? There is air along the cardiac margin. Here too, we can see the cardiac margin is fairly sharp here, as sharp as it is here on the right side. And this suggests there is a medial pneumothorax. So this is not a case of right side pneumothorax, it's a case of bilateral pneumothorax. This is another baby with pneumothorax, with a medial pneumothorax on the left side. Many times we get confused with pneumomediastinum. But in a pneumomediastinum, however small the lobes of the thymus may be, usually the thymus gets lifted up. So what about in pneumothorax, either the thymus gland gets compressed or may not be visible. This is another X-ray showing a large collection of air from sail sign appearance of a normal thymus. The sails, Seneca's Spain's sail sign is named after the head sail of a boat, which has got a similar shape. This is a baby with pneumomediastinum. You can see the thymic gland, which is a little lifted up. But the most important thing is this wedge-shaped thymus is not wedge-shaped here. As we see here in the previous X-ray, we can see a wedge-shaped thymus here, which is not so the case here. It's a bit compressed here. This tells us there is an associated pneumothorax also. So there is a medial pneumothorax sitting here along with a pneumomediastinum. This is a lateral view of X-ray of a baby with pneumomediastinum. We need to differentiate it from pneumopericardium. In pneumopericardium, we see air underneath the inferior surface of the heart. So now we'll move to pneumopericardium. Among all the air leaks, air leaks, this is one of the dreaded air leaks, second most dreaded air leaks, next only to air embolism, that is pulmonary pericardium. Fortunately, this is rare nowadays with more sophisticated ventilators and other aided therapies. It too, like other air leaks, it can be caused by high ventilator settings. Majority of these cases occur in infants ventilated with high positive inspiratory pressures, peak inspiratory pressures, high mean airway pressures, and long inspiratory time. And how exactly it develops? Pneumopericardium occurs when air in the pleural space or in the mediastinum, it's supposed to enter the pericardial sac through a defect that is located at the ostia of the pulmonary veins. The diagnosis is suspected when there is a sudden clinical deterioration, and there will be features of cardiac tamponade features, tachycardia, narrow pulse pressure, hypertension, low voltage complexes, and there may be a muffling of the heart sounds as well. Diagnosis is mainly by transillumination, chest radiographs, chest X-rays show air completely encircling the heart. And how we need to intervene we need to intervene urgently if such case occurs. Cardiac tamponade can be life-threatening and requires immediate drainage. If we see a pneumopericardium with no symptoms, even then many people advocate active intervention. How do we intervene? By needle aspiration. We use a sub-xiphoid route. We need to drain this as a temporary measure by using a needle. And then, of course, ultimately, we need to put a chest drain into the pericardial cavity. This is the baby with showing air encircling all around the heart. This is the halo sign of pneumopericardium. This is this is the best feature of pneumopericardium, the hollow sign. And here we see the baby not having a AT tube here. This is somewhat rare. This baby surprisingly happened to go on to have a pneumopericardium when the baby was on CPAP. This is a baby, intubated baby being intubated, and for our respiratory distress syndrome. And there are features of pulmonary interstitial emphysema on the left side, and there is a pneumopericardium on the left side, pneumopericardium. And we can see the airs in the inferior border of the heart margins also. If you say the inferior heart margin, most likely this has to be a pneumopericardium. But sometimes in the AP views, frontal views, there may be presence of air in the inferior borders of the heart if the baby is having a pneumomediastinal as well. So for that, we need to go for lateral X-rays. Lateral X-ray, we can see this thin air column on the anterior aspects, the posterior aspects, as well as the inferior aspects of the heart, inferior of the cardiac shadow also. This is pneumopericardium. And if this was a pneumomediastinum, we can see air in the anterior aspect as well as in the posterior aspect. But we will not see air in the inferior aspects of the heart because there is a central tendon of the diaphragm which attaches to the pericardium. That's the reason it's just the air can't dissect this central tendon. This is the baby with pneumopericardium. There is a pneumothorax and there is a subcutaneous emphysema. And surprisingly, this baby also doesn't have a ET tube here. This was non-invasively ventilated. And these are very rare instances. That's really it's almost always such kind of appearance, especially pneumopericardium, happens with mechanical ventilation and when we are using high pressures. And such rare pictures usually, such cases usually gets published. We'll move to another important air leak, that is pulmonary interstitial emphysema. This pulmonary interstitial emphysema typically is seen in very low birth weight babies with RDS on mechanical ventilation in the first 4 days of life. Not that it does not occur in term babies, it can occur in Meconium Aspiration syndrome and in babies with pneumonia as well. But usually it's seen in babies, premature babies. More premature the baby is, more chances of baby developing PIE, and especially if the baby is intubated and mechanically ventilated. However, PE can also occur with if the baby is on nasal CPAPs or nasal IPPVE. And how exactly this PIE develops? If these tiny babies, especially the premature ones, if they are being ventilated under pressure, if we are trying to give a pressure to open up the alveoli, there may be a rupture of the alveoli. This rupture happens usually typically at the junction of the bronchial and the alveolar duct. And after the rupture, the air escapes into the pulmonary interstitium. From there, the air moves into the perivascular connective tissue surrounding the alveoli, and the air may follow the track along the lymphatic sheaths to the hilum of the lung as well. We know in preterm infants, the interstitium is more abundant than in term. And so once air enters this area, here it can stay in the perivascular sheaths, and this leads to PIE. So once there is development of PIE in a baby being ventilated, there will be decrease in lung compliance, and the gas gets trapped in the interstitium and compresses the airways. And this also increases the airway resistance as well. So this PIE can be localized in one lobe or one full lung, or this PIE can be diffuse disease involving both lungs as well. Then how does it present? Unlike say tension pneumothorax, it does not present dramatically. It develops slowly over a period of few hours. It cannot be diagnosed by clinical examination. It is diagnosed on chest X-ray. But clinically, we can suspect its development when we face a situation wherein there is a gradual hypoxemia and hypocapnia. worsening leading on to respiratory acidosis. And PA can also cause decreased venous return, and this venous return in turn can cause metabolic acidosis as well. So we can have both respiratory and metabolic acidosis developing in babies with PIE. And of course, with the introduction of surfactant and new ventilator modalities, the incidence of PIE has decreased, but still we need to be very careful. We should be conscious and aware, as it can be a precursor to pneumothorax. It can also trigger intraventricular bleeds in premature babies with the development of pneumothorax, or without pneumothorax, it can cause intraventricular bleeds in premature babies. And a baby developing PIE can go on to have BPD as well. So the diagnosis is mainly radiological, and many times chest X-ray is asked for other purpose. Only then PIE gets detected. And how does it appear on X-ray? PIE appears like a linear, coarse, non-branching radiolucencies. Usually is projected towards the periphery of the lung in a very disorganized fashion. Here we need to differentiate from airbrocogramms seen in babies. And PIE later on X-rays, the linear lucencies can become cystic. And these small lucencies may vary in size from 1 millimeter to 3 millimeters. And this is an X-ray of a baby on the left side with respiratory distress syndrome. We can see here reticulogranular opacities of the lung. The cardiac silhouette is obscured. We can see airbroccogram. The linear fine branching lucencies may follow the normal anotic distribution similar to the bronchial tree. And these are not very extending to the periphery as such. But what about here on the right X-ray? Here the baby has got a PIE. We can see lucencies here. There are linear, coarse, and non-branching. And predominantly we can see them on the periphery of the lung. And we can see small cysts also here and there. This is a baby with being ventilated, and the baby has got a PIE on the right side. We can see linear opacities. Here too we can see linear opacities, and we can see small cysts. And this is the baby being ventilated for respiratory distress. And on the left side, we can see a nice airbroccogram with showing normal branching pattern, smooth here. But how about on the right side? We can see they are slowly developing PIE on the right side. And this is very important. We can see the linear opacities which are not branching. And we can see small cysts also developing on the right side. It's very important to diagnose at this stage itself. We have to be very cautious while ventilating. We need to change our strategies at this stage itself. Probably we may have to go for other modes of ventilation, like high frequency ventilation, if it is available in our units. And otherwise, because of the worsening compliance and high pressures, we end up having this baby having pneumothorax. And this is a baby with pneumothorax on the left side. We can see the pulmonary interstitial emphysema on the right side. Many times we be ventilating babies and the babies develop pneumothorax, and we put a chest tube, and after the chest tube, once the lung gets expanded, and PIE shows up, and shows up on the burst lung, and PIE also can be detected on the other side also. Many a times PIE can get missed. And coming to the treatment aspect, we need to prevent PIE from occurring. That's the most important thing. For preventing PIE, it starts right from the labor room. We need to be very careful right from the delivery of the baby itself. Try and prevent asphyxia from developing. If you happen to use positive pressure ventilation, better to use a T-piece resuscitator than a bag and mask ventilation. Introduction of CPAP in babies who are grunting is very important, and also early surfactant therapy is essential. Supposing if we happen to ventilate these babies, and we should not be very aggressive with the pressures, and we should not try and achieve a perfect ABG. But once a PE develops, it's really challenging. It's very tough, even in experienced hands. And if the baby is on ventilator and if the baby develops PIE, the often used strategy is to reduce the inspirator time and peak inspirator pressure, along with adjusting the PEEP just enough to stent the airway. To obtain an optimal PEEP, we need to closely monitor the oxygen need. Probably we may have to increase the FiO2, and in the process of obtaining optimal PEEP, we need to closely look at the work of breathing of the baby, and also the perfusion status of the baby. Also, we need to accept higher PCO2 levels and oxygen requirement. Accept a higher PCO2, say in the region of 54, 55, or a saturation of say 88, 89, 90. Though the ideal saturations for small premature would be 93, 94, 95. But we need to accept slightly lower for some time at least. And coming to the role of high frequency ventilation in PIE, and high frequency can help in early resolution of PIE by providing ventilation at lower mean airway pressures. There are studies which say jet ventilation is preferable. Oscillators too do a good job, and high frequency ventilations are the best in treating babies who have bilateral diffuse PIE. And in babies who have unilateral PIE, in such babies, lateral decubitus position should be considered as early as a first line and therapy in the management, and it should also be used successfully in babies who have bilateral PIE if one side is more significantly affected than the other side. How do we do the lateral? We need to keep the baby in the lateral decubitus position, and with the affected lung as a dependent lung. This results in plugging of the dependent airways and improved oxygenation of the non-dependent lung. And there are other ways of treating UAE by selectively intubating the contralateral bronchus and ventilating. And lobectomy is indicated in a small number of patients with localized PAE when medical management has failed. Now, coming to the less common air leaks, these are mainly pneumopericardium, subcutaneous emphysema, and systemic air embolism. Pneumopericardium is quite uncommon type of air leak. It occurs when extrapulmonary air gets into the parental cavity. Really, nothing needs to be done. Only thing is we need to differentiate it from GI causes of like perforation and other causes. And subcutaneous emphysema, usually it's of no clinical significance. A very large, maybe in the neck, subcutaneous emphysema can compress the trachea. Management is mainly observation and decreasing the ventilator settings. That's the only thing we can do if there is a subcutaneous emphysema. Air embolism, there is no specific treatment for that, and it is invariably fatal. This is a baby with pneumopericardium. Many times the pneumopericardium is associated with pulmonary air leaks like pneumothorax or pneumopericardium. And this is a baby with lots of air in the right atrium. And these are very almost certainly fatal. And before I talk about pulmonary hemorrhage, just key learning points in pulmonary air leaks. Newborn caregivers should have a very high degree of suspicion when we are treating with air leaks. We need to diagnose very early and intervene early. And the air leaks are associated with increased morbidity and mortality. They can cause intraventricular hemorrhages in preterm. Very low birth weight is more likely to lead to BPDs. Extremely low birth babies, more chances of cerebral palsies. A good and gentle management strategies are needed to deal with pulmonary air leaks. And another important topic, pulmonary hemorrhage. And this is characterized, pulmonary hemorrhage is just like uh, severe tension pneumothorax and pneumopericardium is one of the dreaded emergencies in newborn unit, which no newborn caregiver would like to face. It's a nightmare for neonatologists. Many a times it is characterized by massive bleeding within the lung, parenchyma and airways, and carries a very high mortality, about above 50%, even in best of centers. And coming to the risk factors, if you go by the Western literature, it is mainly the prematurity, respiratory syndrome, surfactant therapy, and in babies who develop PDA. However, the 1960s and 1970 Western literature they talk about pulmonary hemorrhage occurring more commonly in term babies. But nowadays, it's drastically reduced there. The incidence has reduced there in term babies. However, we in developing countries, we see uh, lots of pulmonary hemorrhages occurring in term babies, especially those babies with asphyxia, pneumonia, sepsis, IUGR babies, and babies with hypothermia. And coming to the pathophysiology, how it develops, it's not really understood. And many consider pulmonary hemorrhage to be an extreme form of high permeability pulmonary edema. And in premature babies, it is more likely to be secondary to the sudden decrease in pulmonary vascular resistance, causing increased left-right shunting. And this increases the pulmonary vascular engorgement, which causes pulmonary edema, develops now, and ultimately the pulmonary capillaries rupture. This leads to this is especially true in babies with patent ductus arteriosus after surfactant therapy. This pathophysiology typically happens in premature babies, but pulmonary hemorrhage can happen in other situations also. In babies with asphyxia, may develop myocardial failure leading to left ventricular failure, which can lead to pulmonary edema, then increase in pulmonary pressure and pulmonary microvasculature, and from there bleeding occurs into the alveolar spaces. In IUGR babies, pulmonary hemorrhage occurs because they have abnormal pulmonary vasculature, which can lead to pulmonary hemorrhage. And these babies are more commonly to have other comorbidities also, like polycythemia, and they may have hypothermia, sepsis. So a combination of these conditions can contribute to the development of pulmonary hemorrhage in IUGR babies. Then how exactly pulmonary hemorrhage presents? It occurs in term babies, usually in the first 12 to 24 hours. And but in premature babies, usually occurs 48 to 72 hours of birth. In premature babies, many a time the story would be acute deterioration of baby who was actually improving after surfactant therapy. And how does pulmonary hemorrhage gets detected clinically? There may be oozing of frothy pink secretion, and then fresh blood secretions from the nose or the mouth, or if the baby is on ventilator, from the ET tube. This kind of presentation happens in around 30-35% of the babies. But in majority, just a rapid deterioration and instability usually follows after pulmonary hemorrhage. There may be apnea, cyanosis, hypertension, poor systemic circulation. Then the baby will find the baby to have increased work of breathing, hypoxia, hypercapnia, requiring increasing ventilator support. And in such a situation, we go for X-ray. In a baby who has been ventilated for RDS, just prior to the development of pulmonary hemorrhage, the X-rays would show a fairly normal improvement. But once a pulmonary hemorrhage happens, then the X-rays may show a very worsened picture. And this X-ray of a baby with pulmonary hemorrhage shows worsening of the disease with bilaterally fluffy infiltrates. And this is as we see in pulmonary edema. Sometimes we see a complete whiteout in severe cases with just air bronchogram visible. And how do we manage? Investigation wise, apart from X-rays, when we do our blood gases, all components of blood gases show deterioration. And we can see a severe hypoxia, hypercarbia, and metabolic acidosis. When we go for biochemical parameters, sugars can be low. There may be hypocalcemia, hypoalbuminemia, and there may be deranged electrolytes. We may need to watch closely the renal parameters also. And we need to do a proper septic workup also. And coming to the treatment aspect, its treatment is mainly supportive, and the steps normally we take with the pulmonary hemorrhage when the baby goes in for a pulmonary hemorrhage is: number one, immediate resuscitation; number two, decrease in bleeding, try and stop the bleeding; number three, improve the gas exchange; number four is try and find the cause of bleeding. Uh, Coming to the resuscitation, we need to stick to the ABC of resuscitation. If the babies are not intubated, after suctioning, we need to intubate these babies and mechanically ventilate. And in babies who are ventilated, uh, uh, we need to do a gentle suction of these babies. Uh, we usually tendency have to try and remove the ET tube. It's better not to remove the ET tube. Once ET tube gets removed, it's very difficult to intubate in such situations. And we just need to do a gentle suctioning. That's all is required. More. That's better than reintubation. We need to increase the oxygen support, increase the FiO2. We may need to increase the mean airway pressures, especially by increasing the PEEP. And the PEEP, peak inspiratory pressure, we need to adjust by looking at the chest expansion and also looking at the blood gases. And another important is the high PEEP, positive index pressure, may be required. We may have to, a PEEP may be in the range of 6 or 7 may be essential. Some advocate PEEP of nearly 10. This high PEEP serves two purposes. One is it is needed for adequate ventilation and oxygenation. It is also acts like a tamponade and stops the bleeding. And coming to the fluid management in these babies is very challenging. And if there is any decreased perfusion or hypovolemia, a bolus of normal saline may be required. So also collates may be required. Inotropies may be required. However, if we need to keep on reassessing, many times there may not be severe hypovolemia. We should not overload the circulation, especially in the presence of PDA. If there is LV dysfunction also, a fluid restriction may be required. And some advocate a dose of injection furosemide as well. We may need to give blood transfusion, Paxils, and FFP may be needed by looking at the coagulation profile, PT and APTT, and these sick babies, because these sick babies over a period of time can develop a secondary DIC also. And coming to the surfactant therapy in pulmonary hemorrhage, paradoxically, although surfactant can precipitate pulmonary hemorrhage, there is a role of surfactant therapy in pulmonary hemorrhage, but it has to be given after stabilizing the baby on ventilator. A single dose of surfactant is suggested to improve the oxygenation, and surfactant helps because the hemorrhagic fluid would have deactivated all the endogenous surfactant. And about antibiotics, sepsis is a recognized cause of pulmonary hemorrhage. This broad spectrum antibiotics should be started after taking adequate cultures. Then there are other therapies are also tried. Arterial instillation, controversial. There is not much evidence. And PDA ligation, again controversial. Of course, surgical treatment of PDA may be advocated here because medical treatment, because with drugs, what we use for drugs closures, mainly indomethacin and ibuprofen, are contraindicated in the presence of deranged coagulation profile and because of active bleeding. And there may be a role of IV paracetamol in situation, but it is debatable. And people have tried injection hemocoagulase, both for as a preventing pulmonary hemorrhage as well as therapy. And there is a role of some role of prophylactic indomethacin, prophylactic endometriosis to prevent babies, especially extremely premature babies, from developing pulmonary hemorrhage. These babies, they advocate what is called as early targeted therapy. The babies are screened by echo. Babies who are less than 12 hours of age, they give start on indomethacin therapy and try to close the ductus. And there is some evidence to show there is a reduced incidence of pulmonary hemorrhage in such babies. This is an extremely premature babies. And coming to the outcomes and prognosis of pulmonary hemorrhages, the outcome is dependent on the cause. Studies have shown death rates are very high. It's 30 to 50%. Increased incidence of BPD in survivors, increase in risk of pulmonary ventricular leukomalacia and seizures at the age of 18 months. There is increased incidence of cognitive delays and cerebral palsy in babies who survive. And the key learning points in pulmonary hemorrhage, it's a catastrophic complication in already sick ventilated preterm babies. It should distinguish from a common occurrence of small traumatic beat when which happens. The pulmonary hemorrhage can be rarely cause hypovolemia and rarely caused because of coagulation problems. And the risk factors of developing PI are extreme prematurity, growth restrictions, surfactant therapy, and the PDA. The mainstay of treatment includes ventilation, vigorous resuscitation in a shocked and critically infant. And these are my references. And thank you so much for the patient hearing. Thank you.
Ajay?
Yeah, tell me.
Yeah, I mean, you've completed your presentation, right?
Yeah, I've completed.
All right, all right. We'll quickly thank you for the wonderful presentation, and I'm sure a lot of questions are already coming in. So we'll move on to the next presentation. So I request Dr. ANITA.
Yes, sir.
Yeah. So she's a consultant neonatologist at Shanti Hospital, Bagalkot. And she has
Yes,
done
sir.
MBBS from JNMC Belgaum and MD Pediatric, as Guru Prasad sir told, from Davangere, and DNB Neonatology from Mehta's. And I know her personally, that she's a university gold rank holder and a gold medalist, and she's got 7 publications. Wonderful achievement at your age. Thank you very much for being a part of it. Over to you, Dr. ANITA. Please start the session.
Thank you, sir. Thank you, Prashant, sir, for that introduction. And am I audible, sir?
Yeah, you are audible. Please go ahead.
Thank you, sir. So first of all, I thank NNF Karnataka State Chapter for giving me this wonderful opportunity. And I would also like to thank you for allowing Guru Prasad sir to introduce me. It's an honor to be introduced by one's own teacher. So I will always remain indebted to you, sir, for those kind words. And whatever I'm going to present today is a reflection of your teaching. So here I begin my presentation on Meconium Aspiration syndrome with specific reference to the management of this entity. So we all have managed a lot of cases of Meconium Aspiration syndrome throughout our training and also further into our practice. So we have seen a lot of challenges. We have also come across a lot of new management options while managing these babies. So what is new in today's presentation? So why are we so anxious about Meconium Aspiration syndrome? It's basically because it is associated with certain potential dangers right from the labor room itself. Because it is associated with perinatal hypoxia, it is associated with airway obstruction at birth, and also it can cause very significant pulmonary vasoconstriction. So with all these factors coming into play, it becomes very challenging to manage a baby. Yes, we know this. So what is so new about today's presentation? Apart from the basics of Meconium Aspiration syndrome, I thought I would be highlighting certain aspects of delivery room management, the newer aspects in NRP that have come up. The second thing is, how do we manage Meconium Aspiration syndrome at a resource limited setting? And at the other extreme, how does a person who has got access to extracorporeal membrane oxygenation manage a baby with Meconium Aspiration syndrome when everything else fails. So this is what I'm trying to cover apart from the basics of meconium aspiration syndrome. So coming back to basics of meconium, that it is mainly composed of water. 80% of it is constituted by water. There are many other components in it. So most of them are responsible for the inflammation that meconium is causing in the alveoli. Further, by 8 to 10 weeks of gestation, meconium is appearing in the fetal intestine. Anal sphincter gets innervated by about 20 weeks of gestation, and meconium passage is uncommon between 20 to 34 weeks of gestational age. So every baby who has got meconium staining of amniotic fluid, does it end up with meconium aspiration syndrome? That we need to look for certain risk factors wherein a baby with meconium staining of amniotic fluid can go into meconium aspiration syndrome. So these are some of the risk factors wherein a post-dated baby or a baby with a fetal distress, a baby who is SGA or LGA, or who is depressed at birth, or who undergoes positive pressure ventilation at birth. These are the babies who are at risk for meconium aspiration syndrome. And this is another graph which is showing that with advancing gestation, we see that there is an increasing incidence of meconium staining of amniotic fluid, as well as increased incidence of meconium aspiration syndrome. So with this, we define meconium aspiration syndrome as a baby who is born through meconium staining of amniotic fluid, who has got respiratory distress at birth, and also has a typical chest radiograph. And symptoms cannot be otherwise explained. But still, we do see a lot of babies wherein chest radiograph is not very typical, but they end up on ventilator, they have very severe PPHN. And at the same time, we see all the findings on a chest radiograph, but baby is comfortable with minimal oxygen. So basically, meconium aspiration syndrome is a spectrum of manifestation, and this is a triad which is seen most commonly in babies, but there can be other manifestations, and meconium aspiration syndrome can be overall a spectrum and not a single disease entity as such. So coming to the incidence in developing countries, from one of the studies I could get this, that in developing countries, 10% of all the respiratory failure in neonates is attributed to MAS, and 20 to 40% of them develop PPHN of varying degrees, and mortality is about 20% in this particular study. This can be either more or less depending on the setting that we work with. So coming to how do we assess severity of meconium aspiration syndrome? So it is based on the FiO2 requirement of the baby and also the duration over which I give this particular oxygen. And if a baby requires assisted ventilation for more than 48 hours, then it is severe meconium aspiration syndrome. So are there any ways in which we can prevent this aspiration syndrome? Yes, if we are able to induce labor by 41 weeks, we can bring down the incidence of MAS to some extent. But at the same time, we need to give appropriate ANC for our mothers, because those who are having chronic uteroplacental insufficiency, they are at very high risk for developing meconium aspiration syndrome. So meconium is something that does not appear only at birth. It can start right from 8th week of gestation, and baby is at risk of aspiration anytime in utero, and we need to be aware of this. A fetal gasp is enough to aspirate meconium into the airway and cause further problems in a baby. So there was something more tried to prevent MAS, that is amnio infusion. In a mother who has got severe oligohydramnios and fetal distress, saline infusion into the uterine cavity was tried to relieve the pressure on the umbilical cord, and it helped some mothers. But when put into a research setting, this was not found to be very useful, and it had its own implications and complications like amniotic fluid embolism, and people were scared to try it or uniformly recommend it across the settings. Another intervention that was tried for prevention of MAS was in utero endoscopic suctioning of meconium. As it is, this intervention itself seems to be very scary to put it across a uniform setting. But it was tried in one of the settings, a very good setting in which it was tried, but it did not yield the expected results of prevention of MAS. So that was also given up. So coming to the pathophysiology of MAS, so I have made it into a question answer format so that we can understand it better. So we want to know, when is meconium aspirated? Is it only at birth? Not necessarily. It can get aspirated even in utero. A fetal gasp, because of the fetal hypoxia itself, there can be in utero aspiration of meconium, and by the time a baby is born, it may already be very sick. So what stimulates this intestinal peristalsis in utero? It is stimulated by fetal hypoxic stress or by vagal stimulation. And how is this fetal hypoxia brought about? It can be acute intrapartum event like abruptio placenta or placenta previa, or it can be a chronic in utero insult like PIH, which is evidenced by elevated erythropoietin levels in mother as well as the baby. So meconium is antenatal as well. It is not always an intrapartum or a postnatal event that we are looking into. So why preterm babies pass meconium less commonly? Because term or post-term babies respond to stress differently compared to a preterm baby. And GI immaturity in preterm is also a probable cause why we do not see preterm babies being born with meconium aspiration syndrome. And one more reason, when a preterm baby is born with meconium staining of amniotic fluid, we usually think of fetal diarrhea, or it can be just a bilious staining of amniotic fluid, or it may be sepsis, especially listeria, that needs to be suspected when a preterm birth with meconium is present. So is meconium staining of amniotic fluid a symptom or a syndrome? So this can be both. It's not always a symptom, or it's not either always a syndrome. It can be very well associated with infection as well as asphyxia. And it has also been found that clinical chorioamnionitis and meconium staining of amniotic fluid, there is no clear-cut cause and effect relationship. They are mutually related to each other, and each one of them can set off the other entity. So at the other end, what is primary and what is secondary MSAF? So when an obstetrician does rupture of membranes and she sees meconium at that point of time, then it is said to be primary MSAF. That is, it is an indication of fetal maturation. So when an obstetrician does rupture of membranes, but she finds a clear amniotic fluid, but later it gets contaminated by meconium, then it becomes a case of secondary MSAF, and that can indicate fetal distress. These are not clear-cut definitions, but they can help us manage a pregnancy or a labor in a better way. So these are only our guidelines on which we can base our management in a patient. So basically, pathophysiology of meconium aspiration syndrome is nothing but interaction of meconium with the bronchial epithelium, with alveolar epithelium, as well as with the host immune system. This is actually an animal experiment. Meconium was instilled into trachea of a baby and it was radio labeled, and then the migration of meconium towards the distal airways was studied. Within minutes, the meconium could move from the trachea to the distal airways, as we see here in the last picture. So this is how fast a meconium can progress, and this is very important. This is very important that we manage these babies in the delivery room appropriately, because golden hour in meconium aspiration syndrome is going to be of utmost importance considering this picture. And this does not end here. By second or third day of life, we also see that meconium is getting aspirated by the macrophages in the lungs. So this is also very well seen here. By day 3, we are seeing macrophages infiltrating the lung and trying to gulp up the meconium into them. So it is an immune activation. This is also an immune activation, and the migration of meconium is also very fast into the lungs. So this is the pathophysiology of meconium aspiration syndrome, and this is a pictorial representation of the same, wherein we can see that meconium, which has been taken into the trachea because of the fetal gas, has migrated distally, and it can cause chemical pneumonitis. It can cause a partial obstruction and a ball valve effect, or it can cause complete obstruction and atelectasis. It can also cause surfactant deficiency. And if at all it is associated with asphyxia and fetal hypoxia, it can also cause ventricular dysfunction. And when ventricular dysfunction sets in, along with pulmonary arterial hypertension, then this case is going to become very complicated to manage further. So these are certain mechanisms which are described in our textbooks as to how meconium aspiration syndrome is going to manifest. It can cause airway obstruction, surfactant deactivation, cytokine and complement activation, vasoconstriction, overall leading to PPHN and respiratory failure. So we all have seen clinical features of meconium aspiration syndrome. We have seen babies being born with yellowish green stained body. We also see features of post-maturity. Baby has got all features of respiratory distress, and auscultation reveals rhonchi and tricuspid regurgitation murmur. So how do we manage these babies when they are born in the delivery room? So before we know how do we manage our babies, we need to train our nurses very well. And this is very important for any setting, be it small or a large setting, wherein we are managing these babies, and especially for busy units, wherein nurses are the first responders when such babies are born. So we need to make sure that our nurses are able to identify the non-vigorous infants and take them immediately of resuscitation with positive pressure ventilation, assessing the heart rate, and they are able to complete all these steps in time. So we need to competently train them so that they can manage these babies effectively. And also, at the same time, we need to break the individual and logistic barriers for nurses while training them. We need to give them simulation training. We need to evaluate their performance periodically. And also, we need to give them a frequent training, because if we leave totally on them, they may tend to forget certain steps, and that may be carried over by the junior nurses. So we need to repeat the training a couple of times so that we are ensured that at least a few nurses are identified as leaders and they can take over the training, and it will percolate further into the junior nurses, and all of them are empowered at a time, and our labor room becomes a cakewalk. So further, then we come into certain guidelines which have helped us in delivery room management of meconium staining of amniotic fluid. So this has evolved right from the time of 1987, wherein a lot of distinction was made between thick and thin meconium. And also, and after shifting the baby to radiant warmer, trachea was suctioned. So in the 1990 edition, free flow oxygen was added to the above guideline. In 1994, again, almost the same guideline continued with a lot of emphasis on the consistency of the meconium. But further moving on, in the year 2000, the definitions of vigorous and non-vigorous infant appeared, and that changed the overall outlook of the meconium aspiration syndrome. So suctioning the mouth and pharynx at the perineum continued, but in 2006, finally, suctioning of the mouth and pharynx at the perineum was given up, and the definitions of vigorous and non-vigorous baby continued. So we all know a vigorous baby is someone who has got good tone, good respiratory effort, and heart rate of more than 100 beats per minute. 11, nothing changed apart from the definitions of vigorous, non-vigorous babies. In the year 2016, something drastic happened. That is the management of vigorous baby. When you say that a baby is vigorous, you need to do gentle cleaning of meconium from mouth and nose with a bulb syringe, and you just carry on with the initial steps of resuscitation. But when a non-vigorous, you do not suction the mouth and trachea. You first start off with initial steps of resuscitation, give positive pressure ventilation to this baby if it is required, and routine intubation for tracheal suction in this setting is not suggested. I repeat, it is not suggested, and it is not a recommendation that you should never do tracheal intubation. It is only that if at all an airway is visibly obstructed with meconium, go ahead, clear the airway with intubation and tracheal suctioning if required. But otherwise, do not delay the other steps of resuscitation just to suction the trachea. So that was the suggestion which was given in 2016. And we are all very proud that this particular change in the NRP algorithm worldwide was brought about only because of 2 Indian authors who dared to conduct 2 big RCTs, and they made a big impact on the NRP algorithm. So about that, I'll be talking in further slides. So this is the pathophysiology of meconium aspiration syndrome as to why these Indian authors thought of bringing about this change in tracheal intubation. So as we can see here, meconium aspiration syndrome can cause pulmonary arterial hypertension by different mechanisms. But there is an added on factor of asphyxia if we spend time on tracheal suctioning, and if there is a nurse who is taking a lot of time to do this, or she is taking a lot of time to call another doctor to get the trachea suction before initiating positive pressure ventilation, we are just subjecting this baby to asphyxia. This asphyxia can cause cardiac dysfunction, that is LV dysfunction, and further it can cause pulmonary venous hypertension. Pulmonary venous hypertension, when it gets added on to pulmonary arterial hypertension, it gets very difficult to treat this baby. So when we have a baby with PPHN along with LV dysfunction, it is very difficult to treat this baby, and this baby is not going to respond to the usual lines of management. We need to take them to things like Milrinone. They need a setup wherein ECMO is there. They need very high ventilatory strategies which need to be intelligently coordinated, and these babies end up in mortality most of the time. So basically, to avoid this whole spectrum of problems, the Indian authors went ahead and thought that why not initiate with initial steps of resuscitation, positive pressure ventilation, rather than spending time on tracheal suction, and see what happens to the non-vigorous baby. And they found that certain interesting results. The overall thing that the concern with the tracheal suction was that we all have seen while intubating a baby, we do face certain transient problems like bradycardia, apnea, laryngospasm, cyanosis, vocal cord bleeding. Hoarseness and stridor can be temporary, or sometimes it can be permanent also in the baby. So we all have seen many of these complications while intubating babies. So hence, these Indian authors have brought in certain changes into the NRP algorithm. So overall, NRP agreed to go ahead with this change because this review of small RCTs showed no difference in outcomes whether the baby was intubated or not intubated at birth. There was lack of evidence to support routine tracheal suctioning because tracheal suctioning as such never showed good outcomes with reference to research. And we were also avoiding potential harm of intubation that was listed in the previous slide. And we are also not delaying the initial steps of resuscitation just for tracheal suctioning. So these were the reasons why there was change in NRP algorithm. So these are the two studies from India, from JIPMER and from LHMC New Delhi, wherein it was shown that one group consisting of no endotracheal suctioning at birth and the other group who underwent endotracheal suctioning at birth, and the outcomes were meconium aspiration syndrome, death, pneumothorax, asphyxia, and a lot of respiratory support that was given to the baby. And it was found that p-value was not significant with respect to these outcomes among both the groups. And as we can see here, the total number of babies in one arm is 149 and the other arm is 148. With very small number, they could come over to very significant outcomes, and they showed that whether you are intubating the baby or not intubating the baby for aspirating meconium in the delivery room, the outcomes do not change much. So this was the reason why we are not routinely suctioning the trachea at birth in a non-vigorous baby who is born with meconium stained amniotic fluid. So we have to individualize the cases. Only when airway is visibly obstructed by meconium, we go ahead and aspirate it. Otherwise, we start off with the initial steps of resuscitation, continue with positive pressure ventilation, and then continue with the usual NRP algorithm unless we come over to intubation. So this is how we are managing the babies at present. Overall, to summarize the delivery room management of meconium aspiration syndrome, this picture is very useful. As we can see here, in the year 2005, amnio infusion was not routinely practiced. It was given up because of the very good evidence given by Fraser in NYAM journal. In the year 2004, suctioning at delivery of the head stopped. In the year 2000, Biswell was the person who defined vigorous and non-vigorous babies. Biswell is an author who has done a lot of work on meconium aspiration syndrome, and we owe a lot in the management of these babies to this particular author. And in the year 2015 and 2016, we see these two Indian authors, Dr. Chatri sir and Dr. Nandia ma'am, from JIPMER and from New Delhi respectively, who have contributed a lot to the management of non-vigorous babies. And if we carefully look at this picture, the number of babies in other studies were somewhere around 2000 and 2500, whereas the Indian studies could bring out this recommendation with just 122 and 175 babies. Obviously, there was a lot of controversy, there was a lot of questioning done on these two studies. Even that I'll be discussing. So further, people looked into, after adopting this particular guideline, did the outcomes change in the babies? So people wanted to look into this aspect as well, and further studies were conducted. So these were the term infant outcomes, and phase A was prior to 2015 when routine tracheal suctioning was carried out. Phase B was after the 2016 guideline when routine tracheal suctioning was not done. And it was found that intubation in the delivery room definitely reduced significantly. NICU admission rate also did not change, because whether a baby is intubated or not intubated in the delivery room, the admissions remained the same. So why do an intervention which can cause potential harm to the baby and cannot reduce the NICU admission? Whereas respiratory support after 24 hours was significantly lesser in the phase 2 babies. So this was just one study. There was another study from California which showed that there was no increase in the incidence or severity of MAS after adopting the new guideline. But there was a concern that intubation skills would go down, they would be on a decline if we are not intubating these babies enough in the delivery room. At least I personally owe my intubation skills to babies with Meconium Aspiration syndrome. If that is the case with most of us, then the new residents would be losing a lot of opportunity to intubate the babies. But intubation can be learned on other babies as well. We would never need to intubate on an unnecessary occasion just to increase the steepness of the curve of intubation. So I hope like we are all on the right track, and the concern is of course very much real, but still we need to do the right thing to the baby, and we need not do any harm just because we want to learn a new skill. So at the same time, though these studies were encouraging for the Indian studies, there were other studies which was published in Pediatrics in the year 2018, and this came out in contrast to the previous two studies. This particular study has shown that the incidence of Meconium Aspiration syndrome did not increase, but at the same time, the need for respiratory support and the respiratory issues in these babies, in the non-vigorous babies, definitely increased after adopting this guideline. So based on this particular study, still the questioning and the controversy around this particular suggestion in the NRP algorithm goes on, but we always have a scope for a bigger study and a multi-center study wherein we can answer this particular question effectively. So coming to the treatment of Meconium Aspiration syndrome, the mainstay of treatment is supportive therapy. Baby needs to be euthermic, euglycemic, eucalcemic. We need to avoid polycythemia and metabolic acidosis in these babies. So availability of assisted ventilation is crucial for these babies. We need to have a backup of pulse oximetry and ABG. Sedation and analgesia are equally important because we want to avoid ventilator asynchrony, reflex catecholamine release, and worsening of pulmonary vascular resistance. So we need to effectively manage PPHN by avoiding acidosis, stabilizing blood pressure, by giving adequate sedation, and also using pulmonary vasodilators as required. So coming to something interesting, that the neuromuscular blockade in a baby with MAS. So can I give Vecuronium to this baby? Can I give Vecuronium infusion or a bolus dose to this baby? Yes, I can reduce the agitation, hypoxic episodes, oxygen consumption, accidental extubation. But at the same time, I'm putting this baby at risk for something else. I'm increasing the chances of atelectasis. I'm increasing the chances of ventilation perfusion mismatch, and also the risk of mortality goes up by using the neuromuscular blockade agents. So this has to be a very individualized decision for any baby, and this needs to be done only if sedation and analgesia is not able to calm a baby or is not able to take care of the PPHN. So we always need to remember developmentally supportive care along with all the other therapies that I have discussed, because that can bring down the severity of PPHN to a great extent. So coming to nasogastric aspiration, this is one of the practical issues that we face in labor room. Whenever a baby is born with meconium staining of amniotic fluid, we always put NG2. We want to see how much meconium is there in the stomach, and we also go to the extent of showing it to the attenders and telling them that this is what is there in baby's stomach, and this can any time get aspirated and worsen the pneumonia in this baby. So I have aspirated this much of meconium. So are we really right in doing this particular intervention? So people have put in studies to see whether inserting an NG tube and aspirating the stomach contents is really helpful, because we wanted to see if at all that can bring down the rates of secondary MAS, whether it can bring down the rates of feed intolerance in these babies. These are valid questions. So there were about 6 studies which were conducted, and a review was done by Deshmukh et al. And it was shown that reduction in feed intolerance by about 30% could be achieved by doing a simple nasogastric aspiration at birth and taking out the meconium from the stomach. But at the same time, secondary mass was not assessed as an outcome, and these studies were underpowered to take it as an outcome. So there could be no final word said about the secondary mass prevention by doing the nasogastric aspiration. So all the 6 studies that were done in this regard had a very high risk of bias, subjectivity, as well as confounding, because of which nasogastric aspiration is not routinely spoken about when we are talking about management of MAS. So coming to the respiratory support, which is very vital for a baby with Meconium Aspiration syndrome, we all know that previously we all thought that CPAP was contraindicated, but nowadays 10% of the babies are managed only with CPAP alone, whereas 40% of the babies go on to require mechanical ventilation. So these are the babies with severe MAS. So the target O2 saturations are to be maintained between 90 to 95%. Target PaO2 recommended is about 90 mm of mercury, which is slightly higher than the usual targets of PaO2. But at the same time, it is very crucial that we provide adequate oxygen to the baby. And fear of giving too much oxygen is something that takes over us. And we are always worried about whether this baby is going to develop complications of pre-oxygen radicals. So further, we are worried about that. But anyway, these are term babies. Overall ROP risk is very low in these babies, and we also need to effectively manage PPHN. So there is a school of thought which says that the target O2 saturations can reach up to 99% while managing a baby with severe mass with PPHN. So that is a different school of thought altogether, and that has a different discussion altogether, and it is beyond the scope of today's presentation. So I have just made a comment and I've just stopped there. But the overall concern as to why these people are thinking of giving too much oxygen and actually maintaining adequate oxygenation in these babies is that we are all worried about pulmonary vasoconstriction and worsening of PPHN. Though there are many articles which have come up which tell us that O2 saturations need to be maintained to less than 95%, there is a separate school of thought who say that saturations can go up to 99% in selected babies. So there are some issues with target saturations in this, and I think as of now, the final word is that target O2 saturation should be 90 to 95%, but sometimes we need to individualize it based on the severity of PPHN. So coming to more about CPAP, using CPAP for Meconium Aspiration syndrome, a trial of CPAP can be given when FiO2 requirement is about more than 40%, and we need to individualize the need for CPAP. If X-ray is showing a lot of hyperinflation, and if I'm seeing a clinical hyperinflation of the chest, then I refrain from using CPAP in such babies because it would not be prudent to use CPAP for such a baby. Whereas I would like to go for ventilation in such a baby who has got a very obvious
Just call up mode. Yeah, I think we
Prashant?
just lost Dr. Anita.
Prashant, you please
yes,
call
sir,
her,
yes, sir.
Dr. Prashant.
Can you hear me? Yeah. We have called her. She's joining. I think suddenly she's joining in a minute. She's
joining from new host, sir, by name Sony. I have made it.
Hello, sir.
Yeah. Please continue.
Sorry for that interruption. Yes. Yes, sir.
Please
Can you hear me, sir? Am I clear, sir?
Yeah. Very clear, very clear. It's going well. Please continue.
Thank you, sir. I'm sorry to be interrupted in between. So I would like to continue with the presentation. So here I'm dealing with a heterogeneous lung. And as we can see, I need to ventilate the areas of collapse as well as hyperinflation at the same time. So if I am going ahead with a controlled ventilation, I may not be able to uniformly ventilate this lung, and I may end up with pulmonary air leaks in areas of hyperinflation. But at the same time, if I keep my pressure low, I may not be helping the areas of collapse. So how do I go about this particular lung? So as we can see here, the colored dots are babies with Meconium aspiration syndrome. And if you see this particular dot, it has got very low compliance, but a very high FRC. That is, this is a hyper expanded alveolus. Whereas at the same time, the blank circle, which is a normal baby, as we can see, all of them are falling between the 95% confidence interval. And this is another baby with Meconium aspiration syndrome who has got a very low compliance as well as a very low FRC. So this is an atelectatic alveoli, and this one is a hyperinflated alveoli. And if we see the respiratory mechanics of this baby, we can say that there is a very high resistance in the first 48 hours, and there is a low compliance when there is atelectasis, and time constant is high during the first 3 days. So based on this, I need to ventilate this baby, and I need to make sure that the expiratory time is adequate for this baby. And at the same time, how do I manage this baby or the controlled ventilation? So it is not possible. I need to go ahead with the patient triggered ventilation in the form of SIMV or assist control with adequate sedation, so that I can effectively ventilate the lungs of the baby who has got Meconium aspiration syndrome. So coming to high frequency ventilation, when a baby does not respond to conventional ventilation, then this is a rescue strategy, because this can effectively prevent air leaks and adverse PEEP. Ventilation and gas exchange improves, and also there is a reduced need for ECMO after high frequency ventilation has been routinely used for rescuing the babies on Mars. So coming to surfactant therapy, should I give surfactant to a baby with Meconium aspiration syndrome? Yes, if the baby is intubated and FiO2 requirement is more than 50%, and if the chest X-ray is showing a whiteout picture, that is, there is predominant atelectasis, then I can administer surfactant to this baby. Whether to give surfactant as a bolus or as a lavage, it depends on our experience, but it is always better to give it as a bolus, because lavage can take a lot of time, and we may be subjecting the baby to hypoxia, and further we may worsen PPHN with that intervention. So coming to steroids, routine steroid therapy is not recommended in Meconium aspiration syndrome, though it helps lung edema, pulmonary vasoconstriction, and inflammation. It was also studied in one of the journals. An article was also published by giving an early inhaled budesonide therapy, which reduced the oxygen need as well as the hospital stay, but still the final word about steroids has not been said. And all that is known at present is that no routine steroid therapy is recommended in these cases. So coming to antibiotics, we all know that Meconium is a very good culture media for gram-negative bacilli. So should I be starting antibiotics for all the babies? If at all this baby has got other risk factors for sepsis, then it is an yes. And it is indicated if there is evidence of perinatal infection, if there is extensive resuscitation that has gone on to revive these babies, and if the baby is ventilated. Otherwise, antibiotics are not routinely indicated in a case of Meconium aspiration syndrome. So coming to the echocardiogram of PPHN, I'll be covering it in a very brief manner, because enough has been discussed about PPHN. So as we can see, the echocardiographic features are, there is a right to left shunting across TFO as well as PDA. There is a septal deviation towards the left ventricle, and also there is a tricuspid regurgitation jet, the velocity of which can be measured to quantify PPHN. And also we need to look into the left ventricular function and left ventricular output as well. So these are certain echocardiographic features of PPHN. And this is the management of PPHN. We all know developmentally supportive care is of extreme importance in managing these babies with PPHN. And we need to reduce the noise, we need to cover the eyes, we also need to make the baby comfortable in all possible ways. And we need to maintain pre-ductal saturation of more than 90 and a post-ductal saturation of more than 70%. We make sure that lung is adequately expanded. If required, we make use of surfactant. We increase the pressures in conventional ventilation, and if at all the PIP in conventional ventilation goes up to 25 to 28, then we switch over to HFOV, and the starting mean pressures in HFOV are 30 to 40 with a frequency of 10 Hz and amplitude of 13 to 17 and IE ratio of 1:2. This is how we go about managing PPHN mass. So we also have certain pulmonary vasodilators which we try. Only if inhaled nitric oxide is not available in a setting, then the next thing, for a resource limited setting wherein we work, where inhaled nitric oxide is not available, then we can make use of sildenafil, and we can make use of milrinone if there is a LV dysfunction associated with it. So these are the different mechanisms by which the drugs act, and there are certain newer agents that have been implicated into the management of PPHN as well. So then coming to the picture, where exactly are we when we are managing PPHN, which is associated with Meconium aspiration syndrome? We are trying to recruit the lung, we are using the pulmonary vasodilators, and also we are using sildenafil if INO is not available with us. So this is the PPHN picture that we are going to deal when we are having a baby with mass and PPHN. But if there is no PPHN, if it is only Meconium aspiration syndrome, then we have to recruit the lung with surfactant and give adequate PEEP either by CPAP or by ventilator, whichever is good for us. But when the same PPHN gets complicated with LV dysfunction, then INO is contraindicated. That is, we cannot give inhaled nitric oxide to such a baby. We need to depend upon milrinone as well as PGE1. So the choice of inotropes again depends upon a lot of factors. It depends upon whether I'm dealing with a normal blood pressure or a low blood pressure, whether there is good cardiac function or if there is a cardiac dysfunction. So when there is a combination of low blood pressure and cardiac dysfunction and there is rapid deterioration, then we have a choice of extracorporeal membrane oxygenation. And also the choice of inotropes is also vast in this particular scenario, because this is the worst possible scenario that we can encounter when we are managing a baby with PPHN. So coming to inhaled nitric oxide, we all know that there are areas of hyperinflation, but at the same time, the surrounding capillaries may be vasoconstricted. And if we give inhaled nitric oxide, it is going to cause dilatation of these particular vessels, and it is going to cause a match in ventilation and perfusion, leading on to better oxygenation. At the same time, it is not going to affect the systemic vascular resistance, whereas it reduces the pulmonary vascular resistance, and the amount of right to left shunting is going to be reduced by using inhaled nitric oxide. This is the whole idea of using inhaled nitric oxide, and we need to be very careful about the levels of methemoglobin when we are using inhaled nitric oxide. So this is how we start. There are certain rules to start INO, 20-20-20 rule, that is oxygenation index of 20 at the dose of 20 parts per million, and PaO2 by FiO2 ratio should increase by more than 20 millimeters of mercury after 1 hour of starting of INO. Only then I will continue INO. If at all these things are not achieved, then the baby is declared as a non-responder and he needs to go further to ECMO, or we need to make sure his lungs are well expanded. We have taken care of the hemodynamic stability. Okay, so once the baby has responded to INO, after 3 or 4 days, depending upon the response of the baby, we start weaning INO in a 60-60-60 rule. That is, if FiO2 requirement on ventilator has come down to 60% and PaO2 in ABG is more than 60 millimeters of mercury, if I have achieved these two, and then after 60 minutes, I am going to start weaning the INO. So this is the 60-60-60 rule for INO. So I spoke something about oxygenation index. This oxygenation index is nothing but a product of mean airway pressure, FiO2 into 100 divided by PaO2 in the ABG. And it also needs a vascular excess, and the formula can change. The value can change depending upon where exactly I am doing the arterial sampling. But there is something new, that is oxygen saturation index. This does not require a vascular access because I am going to depend upon pre-ductal SpO2 instead of PaO2. So there is no vascular access required. All that I need is a pulse oximeter which is reliable. And how do I calculate saturation index? If at all I have a pre-ductal saturation in the range of 70 to 99%, then this OSI, that is oxygen saturation index, corresponds to about half of OI. That is, for example, if I have OSI of 8, then it is equal to OI of 16. Then coming to the inhaled nitric oxide, it has definitely reduced need for ECMO. It has definitely reduced mortality. Started at a dose of 20 parts per million. And we start thinking about INO once the oxygenation index hits 15. And the moment it comes to 20, I will initiate INO. Sometimes I may initiate even earlier depending upon the severity of PPHN. And by using a high frequency ventilation, I can augment the efficacy of INO. So always we need to remember, the thumb rule is that before using inhaled nitric oxide, I need to make sure that the lung is well recruited, whether with the help of CPAP or with the help of surfactant, conventional ventilation or high frequency ventilation. It is a rule that for INO to act, the lung needs to be recruited, because it is only a pulmonary vasodilator. It can take care of perfusion in the pulmonary arteries, but it cannot take care of the ventilation. We need to make sure by using other modalities that the lung is well ventilated before I actually administer inhaled nitric oxide to the baby. So what is the cost of setting up INO? I found out from my sources, and the cost is obviously a little higher with constant flow devices. And when it comes to variable flow devices, the cost skyrockets to 30 to 35 lakhs. But there are certain low cost INO interventions which are done by certain hospitals, but there are a lot of safety issues with respect to methemoglobin levels and NO2 levels. So we need to be aware of other things before we actually go on to the low cost INO interventions. We better start off with the standardized instruments. But however, there are hospitals who are doing a good job with low cost INO, but we need more literature on the safety and efficacy of INO in such settings. So then coming to the wonder drug, that is sildenafil. For those resource limited settings wherein we do not have INO, then we depend highly upon the sildenafil. So there was a Cochrane review which shows 5 trials including 166 infants, out of whom there were 3 studies which were of interest to us, wherein there were 77 babies, wherein sildenafil was compared to a placebo. And it was found that number needed to treat for an additional beneficial outcome was 3. That is, 3 babies have to be treated with sildenafil to reduce mortality and to improve the parameters of oxygenation. For any drug, this is a very good number needed to treat. That is, for any trial, for any intervention, if the number needed to treat is very less, that means by treating lesser number of babies, we are able to show a favorable or a beneficial outcome. So this is something like surfactant, which had reduced mortality. Similarly, sildenafil has done wonders for settings who are not having access to INO. So Cochrane have themselves have given us a recommendation, a conclusion saying that the sildenafil has got potential for reducing mortality and for improving oxygenation in neonates, especially in resource limited settings where INO is not available. But they also tell us that follow-up of these survivors is still not available. We need to look into these aspects before we can make a uniform recommendation. So sildenafil is available both as oral and IV preparation. Oral dose is 1 to 2 mg per kg per dose used 6 hourly. IV dose is 0.42 mg per kg over 3 to 4 hours as a bolus, followed by 1.6 mg per kg per day as infusion. So, but there are certain practical problems with sildenafil as well. A baby who is NBM and does not tolerate oral drug needs a IV preparation, but IV preparation availability may be limited. Availability of infusion pumps may be limited in certain settings, and balancing systemic hypotension with reduction in PVR may also be difficult because invasive BP monitoring is again an issue in predominant outbound settings wherein there is a very high risk of sepsis for all the babies. So coming to milrinone, this is another drug which we use very sparingly, and if possible with the help of a pediatric cardiologist with a loading dose of 50 microgram per kg over 30 to 60 minutes, followed by a maintenance dose of 0.33 mg per kg per minute. So, and we can accelerate it to 0.66 and 1 microgram per kg per minute. There are other potential agents which have been used in PPHN. So these are some of the centers in India which are offering ECMO to babies. This list is not exhaustive because as of 2017, about 160 machines and 700 circuits were sold in India. And it's been 3 years after that. Definitely many more centers would have taken up ECMO by now. So there are certain selection criteria for ECMO. These are similar to the selection criteria for therapeutic hypothermia. And we need to make sure that we are recruiting certain salvageable babies before they go into ECMO. Because if already the chances of survival are very grim, then there is no point in going ahead with ECMO. So as we can see, ECMO is very useful for a severe mass and refractory respiratory failure on high frequency ventilation. The commonest indication for ECMO in newborns is Meconium Aspiration syndrome, and up to 35% of infants on ECMO are because of mass, and they have got a very high survival rate of 95%. That's a very good survival rate for a neonate who goes on to ECMO. And high frequency ventilation along with INO has definitely brought down the need for ECMO. So this is from Dr. Uma Maheshwari ma'am from SRM, who actually managed a baby with Meconium Aspiration syndrome. After failing all the other options that I listed prior to this, she was forced to go ahead with ECMO for a particular baby. And I was lucky enough to contact her on phone and like just take her views as to what we do not know, what a neonatologist goes through when he or she has to put a baby on ECMO. And she was kind enough to share her experience. This is a story of a baby wherein she says ECMO is only a supportive therapy for all these babies, And meconium aspiration syndrome is the best indication for ECMO in a newborn. And we have to cannulate the internal jugular vein and the carotid artery for ECMO. Selecting the right patient is crucial for a good outcome. And they use a rule of 10, 10, 10. That is a PEEP of 10, delta P of 10, that is PIP minus PEEP, and a respiratory rate of 10. So when you are giving only 10 breaths per minute, you are ensuring adequate rest to the lungs. Then these circuits get heparinized every day. So we need to do neurosonogram every day so that we prevent IVH. 2D echo always shows LV dysfunction when a baby is on ECMO, but we need to make sure that we are giving the right kind of inotrope if the LV dysfunction worsens further. So it is always a teamwork which consists of a perfusionist, a neonatologist, a dedicated nurse, and a resident. So it is always a teamwork that makes a lot of wonders to us. And we always need to aim at decannulation as soon as possible once the baby is on ECMO, just like we want to extubate a baby as early as possible after we have ventilated. So average cost of ECMO for this particular baby who was put on or cannulated for over a period of 5 days was 8 lakhs. This was the total cost of treating the baby for those 5 days alone when the baby was put on ECMO, because the cost of circuit itself is 1 lakh per circuit. And this is a success story of a 5-year-old child who is now attaining all the milestones for age. So this baby was cannulated way back in 2015 and is still in follow-up with madam, and she is very happy that there are certain good outcomes, and this is not a far-off scenario that we think that it happens only abroad and it does not happen in India. So kudos to such neonatologists who are doing a great job at their center. So the future in meconium aspiration syndrome is all about N-acetylcysteine and fetal pancreatic enzyme therapy and many more agents which can actually break the meconium and help the baby breathe well. So sequelae of meconium aspiration syndrome are reactive airway disease and exercise-induced asthma, as there are anecdotal reports. The clinical endpoints depend upon pulmonary vasoconstriction. The long-term neurological outcome depends upon the perinatal asphyxia that is associated with MAS. So coming to the summary of the presentation, trained nursing staff and availability of the same is crucial for management of MAS. Delivery room management has got a lot of newer aspects that we need to know, and we need to know how exactly to manage a non-vigorous baby. There are certain challenges while managing these babies, like transporting them appropriately, prevention of sepsis, PPHN, as well as asphyxia. None of them are easy. And adequate lung recruitment if we are planning to start the baby on inhaled nitric oxide. LV dysfunction can be helped by using milrinone, and sildenafil has shown good outcomes in resource-limited settings. And rescue therapy is, of course, extracorporeal membrane oxygenation. So with that, I would like to conclude that with a lot of teamwork and with using the right kind of intelligence for our setting, we need to individualize these cases and we can champion the cause of management of meconium aspiration syndrome. So thank you for a very patient listening. I once again thank all the teachers, seniors, and my dear friends who are listening to this particular presentation. Thank you. Thank you very much.
Thank you, Dr. Anita. I mean, it's indeed a very detailed and very comprehensive presentation. Thank you very much. And I'm sure all the audience are equally excited to go into the discussion part. So I request Dr. Vijay Kulkarni sir, Dr. Vijay Kulkarni sir, to moderate the session. Vijay Kulkarni sir. Vijay Kulkarni sir, are you there? Yeah.
Hello.
Yes, sir. Yes, sir. We are able to hear you.
Yeah.
Kindly moderate the session. Yes, sir.
First of all, a great congratulations to Ajay and Dr. Anita. You are hearing me, Prashant?
Yes, sir. Yes, sir. Yes, sir. Very clear. Very clear. Please go ahead, sir.
It's an excellent and a lucid presentation by Ajay and Dr. Anita. Lot of newer insights. I think lot of issues by Dr. Ajay about pulmonary leaks and lot of issues he brought about, lot of interesting x-rays he had to show. So really about the management of pneumothorax is very important. We run a busy 50-bedded NICU in SDM. So I really appreciate the way he put it across, very nice management. And Dr. Anita, Anita was very crystal clear. First time I'm hearing her, and really a very nice speaker. I think very amateur. It was as if she was delivering a fantastic lecture. So I really appreciate her.
Thank you so much, sir.
Very, very nice talk and lot of insights. So many insights about ECMO. It was really useful. It was really useful. And I would like the audience to share their questions if any questions are there. Both of them are very important topics.
Sir, a few questions they have directly posted to your chat, I think. If you can open the chat box, or Dr. Dinakar, sir?
Yeah.
Ha, Prashant.
Yes, sir. I think
yeah,
few
yeah,
questions. You've got the question, sir?
yeah. Can I'll just address them?
Yes, sir. Yes, sir.
Yes, sir.
Why?
Gurugale Namaskara.
Gurugale Namaskara. Sir, Dinakar sir, Namaskara. Congratulations. A fantastic session. And thank you so much for involving me in the award. Thank you so much.
ಇಲ್ಲ ಗುರುಗಳೇ, ನೀವು ದೊಡ್ಡವರು, HOD ಅದರಲ್ಲಿ see you are going to do so many government these things works, and you are a knowledgeable person. You are running 50-bedded NICU.
Yes,
Sir, now we will start the questions.
Yes, sir.
Sir, go ahead,
So
sir, one by one, because I have a lot of questions in the Facebook and other things here.
So first question that was asked was why cesarean deliveries cause more incidents in air leaks? Based on your experience, what are the common causes? This is a question posted to Ajay. What is the most common cause of pneumothorax in newborn? If recurrent pneumothorax,
So one by one we take, sir. One by one questions.
Mixed question. Okay,
Yes,
first question. Why cesarean deliveries cause more incidents? Do you have any data on that?
Usually cesarean babies, usually cesareans are done, the obstetrician do cesarean once baby is around 36, 37, 38 years, 31 weeks. And they don't wait till the baby crosses 39. That's when we think the baby's lungs are very mature. But many times the lungs in 37-week baby, the early term babies, 37, 38, they're not very mature. They may still have a surfactant deficiency, and fluid absorption in the lungs has not really happened. So these babies are more prone for TTNs, transient tachypnea of newborns, and these babies tend to have late adaptation. So more chances of them getting involved with our interventions, more chances of them developing spontaneous pneumothorax, or through our intervention, they may have pneumothorax.
We totally agree with Dr. Ajay. We forget that the classification of early term. See, babies, we take them as term if they are only at 37 weeks. Actually, we should deliver a baby who is 39 weeks.
39 weeks plus.
Yes. I think babies' lungs are not still ready for taking up those challenges. And what was the second question?
One is deficiency surfactant, lung immaturity, and fluid absorption.
Yes.
Still does
See,
not
another question which has come up to you. What is the most common cause of pneumothorax in newborn? Common cause of pneumothorax in newborn.
So if you go by literature, I'll go back to the study which was done in 1930s. In 1930, they did a study. They took consecutive X-rays on 700 and odd babies, healthy babies who had normal lungs, and they found that there were pneumothorax in 1 to 2 babies. So 2% of healthy babies, when they were born, they tend to have pneumothorax. And many of the babies, premature babies having respiratory distress, almost nearly 8 to 10% of them go on to have spontaneous pneumothorax. And these may be from the literature point of view, maybe yes. From my point of view, maybe babies in our unit, the ones with Meconium aspirations, the ones we created following
paratrauma.
Paratrauma on
paratrauma and
CPAP. Many
yes.
times it has happened very early. 10 years ago, when we started giving surfactant, we tend to forget the decrease in the pressures. either on CPAP or on ventilators, and they tend to have, we have learned over a period of years, all this.
Okay. Okay. So another important question would be, another important assessment would be unscrupulous resuscitation, especially done by junior residents. Especially
Yes,
this
yes.
can happen. This can cause a lot of.
I created, I remember during my PG days, I created pneumothorax. That was my first year of posting, I remember.
No.
And
Yes,
ultimately we
yes.
had to ventilate, and fortunately the baby did well and was fine later at follow-up.
Yeah. No, I totally agree with you. The next question was, can pulmonary hemorrhage develop in prematures without PDA?
Most of the time, PDS uh, babies, premature babies with PDA and after surfactant therapy, they tend to have pulmonary hemorrhage because there'll be sudden decrease in vascular resistance. And PDA, without PDS too, can happen, just like the way it happens in term babies. Maybe asphyxiated babies, they tend to have myocardial injury. These are the babies, they tend to have left ventricular failure. They go on to have pulmonary hemorrhage. And more of the babies, premature babies, maybe if they have associated sepsis, pneumonias, they go in for hemorrhages. So these are the situations they tend to have, just like how term babies, preterm babies too can have PDS without ductus.
Then the next question is, when do you remove the chest tube when the baby is in the mechanical ventilator? When do you remove the chest tube?
The first thing is, most important thing is this, there has to be a proper lung expansion. Number two is there should not be air leak for at least say 1 day. So then that's the time when we try and remove the baby from the chest tube from the baby. If the baby is on ventilator, do we need to remove the chest tube first, or is it the ventilator after the stopping the baby, removing the baby from the ventilator, we need to chest tube? That's always
it's a challenge.
Practical problem. It's always a practical problem. But if the baby, if we think that the baby needs ventilation for a longer time, and say for a few more days, for a couple of days, and if the pressures are already decreased and there is no need to keep the chest tube there, we can clamp the chest tube, wait for maybe 5 or 6 hours, take a chest x-ray. If then there's no accumulation of air, then I think we can remove it safely.
Now, in our experience, in our neonatal setup, we had couple of occasions where baby is on ventilator. This baby has bilateral chest tubes. It is a big challenge salvaging a baby with MS with bilateral chest tubes. Ideal setting, I would recommend at least minimum of 3 days till the baby's lungs are settled. Reasonably, I convince myself that there is a good improvement or a good chest expansion, because I don't want this baby again to crash once the chest tube is turned down. So I think 3 days should be a good option. Then another question which has come is role of injection reptilase in pulmonary hemorrhage. Uh, what is the role of reptilase? Your experience?
I just mentioned this reptilase injection, that is injection hemocoagulase in my slide. It is a hemostatic agent. It's been tried in pulmonary hemorrhages. There are studies which show they have couple of studies where they've injected injection hemocoagulase reptilase during ventilation in high-risk babies who are more prone to develop pulmonary hemorrhage. And there are studies which have used injection reptilase after the pulmonary hemorrhage has developed. And in both instances, there is definitely decreased mortality after using injection reptilase. And also in babies who have survived, there is a decreased duration of bleed. There is also decreased duration of mechanical ventilation.
Then
So
another
that's
question, I think probably the last question which we'll take up. How sensitive is trans-elimination test in pneumothorax? How reliable is it?
Trans-elimination is fairly reliable. That's one of the best way to diagnose, easiest way to diagnose pneumothorax. And it depends on the premature, whether the baby is premature or is the baby is a term baby. If it's a premature, the sensitivity goes up, maybe 95 sensitivity. And if the baby is a term baby, maybe it is, even then also it is fairly sensitive, maybe around 85% sensitive. It depends on the premature. Extreme premature baby it's very highly, it picks up in a fairly good way.
Uh,
Maybe as sensitive as 95%.
Yeah, I think transillumination, I think definitely has a role in pneumothorax, especially for the beginners. Otherwise, essentially, pneumothorax would be a clinical diagnosis, would be a judgmental diagnosis. On the spot. You diagnose that. Once you start testing more and more babies, having more and more babies putting on the ventilator, then pneumothorax is one part of your package that you learn to handle.
Correct.
Yeah, I think Prashant, I think Dr. Ajay has answered quite a bit of it. I think that is okay, Prashant.
Yes, sir. Yes, sir. Yes, sir.
I think, and thank you, Ajay. It was a lucid
Thank you,
talk.
Vijay. Thank you so much.
Very nice X-rays, interesting X-rays, and a special word on Dr. Anita. Excellent talk. I was really impressed by your talk. Hopefully, we'll call you someday to Dharwad for a lecture. Thank you so much.
Thank you, sir. Thank you so much.
Yeah.
Dinakar, sir.
Yeah. So, sir,
Yeah, Dinkar sir.
Vijay sir, can I take some questions, sir?
For Anita?
Yeah, for both of them, sir. So many questions have come. Can I ask, sir?
Sir, Kedar sir, please, Kedar sir, please.
Well, okay.
Kedar, please.
This is for Dr. Sir, you have one question to you. Preterm pneumothorax. Why it is more common? Somebody has already asked the, I mean, sir has already asked you question. You told it is an RDS. Other than that, is there anything else? Same question somebody has asked. Ajay.
Sir, preterm RDS, preterms, especially the late preterms,
Yeah.
same thing, they have more lung
preterm,
fluid.
extreme preterm, any term, preterm.
Preterm. And they tend to have more lung fluid.
Yeah, other than RDS.
Common cause. So I don't get it, sir.
Okay. See, I think so. It is like this. If it is a preterm, usually because of the negative pressure in the lungs. What happens if the small baby, extreme baby, we are introduce the 2.5 size ETT. So it is chances of getting blocked is very, very common. If it is getting blocked, whoever, I mean, this question is from Varanasi. So if it is getting blocked, there are two problems can occur. Increased negative pressure will occur in the lungs, alveoli. That time two things will occur. First, immediately atelectasis will start occurring. If too much negative pressure, pulmonary hemorrhage also can occur. It's like a near drowning or somebody is smothering the baby. Like that, pulmonary hemorrhage can occur. If it is somewhere ball valve mechanism, because of the ETT block, that time pneumothorax also can occur. So ETT block is a second most common other than RDS. Okay. The same thing, sir. Somebody has asked Ajay, sir. Ajay?
Yes, sir.
Yeah, for you, sir. If it is there any called without any CPR, anything, if spontaneous pneumothorax is there, what we should do, sir? This is from Punjab.
Spontaneous, just born baby or what kind of?
No, spontaneous pneumothorax. That's all the question they've asked. I don't know. So it's a spontaneous pneumothorax without any intervention.
Yes, sir. If the baby doesn't have any symptoms, very stable baby, not on any modes of any positive pressures is being given, just we need to closely observe, follow it up. Most likely another 1 or 2 days, the baby, the pneumothorax is going to resolve by itself. Supposing if the baby is on, say, if the baby is on positive pressures, we need to be more extra careful, sir. If it is a small one, maybe we can wait and watch. If it is large one, yes, definitely we need to probably drain it. Aspirate or drain it.
Yes, sir. Sir, can I add some more thing, Dr. Ajay?
Yeah, sure, sir. Please go ahead. Please go ahead. Sir.
Yeah. If there is a spontaneous pneumothorax, if it is a bigger baby or IUGR baby, don't just neglect it. Even if it is without any intervention, see that, ask your junior doctors. Definitely they were afraid of you people. So that means they won't tell you whether they have done CPR or not. If it is like that, definite no history, please try to rule out connective tissue disorder. So with that, try to look for a ultrasound, any kidney problems are there. Usually spontaneous pneumothorax won't occur unless connective tissue disorders are there, or with that sometimes they have seen kidney problems associated. There are so many articles are there, sir. Sir, and one more thing, X-ray. This is also for Ajay.
Yes, sir.
Ajay, sorry, people have asked you only
Yes,
question.
sir.
I'm
Yes,
sorry,
no problem,
dear.
sir. Yes, sir.
Okay, I think so. They are afraid of ANITA. So, is there any X-ray? How early we can diagnose? Is there any better way to diagnose PIE or BPD in the X-ray?
So X-ray, PIE, again, it's an X-ray diagnosis, and we need to look at the linear opacities, sir, and lesions is early, especially in the periphery of the lungs. And BPD, of course, it's more of a clinical diagnosis. A baby receiving oxygen for more than 4 weeks, 36 weeks post gestational age, and we're still requiring oxygen or some support, oxygen support, and we think of BPD with changes in the lung. And with respect to PIE, earliest changes is initially there will be linear lucent shadows, especially in the periphery of the lungs.
Yes, sir. Prashant? Prashant?
Yes, sir. Yes, sir. Yes, sir.
Can you allow Ajay to put any PIE X-ray? Please, can you allow him to put any PIE X-ray?
Yes, sir. Yes, I'll screen share.
Because another 4 questions are there, that is the reason. Any PIE X-ray. Anything. Single X-ray, single X-ray. Yeah, this is also okay. Any single X-ray add? Hello?
Yes, sir.
Okay. See, whoever listening, okay. Prashant, everybody can listen to me, Prashant?
Yes, sir. Yes, sir.
Yes,
Yes,
sir. Yes,
sir.
sir. We are able to hear.
Okay, I request everybody here, just touch your mobile screen or your laptop screen, enlarge it, enlarge the X-ray, go to the periphery as well as mediastinum. Everybody, please. Okay, when that is the reason, pneumothorax or PIE, pneumothorax is easy, subtle pneumothorax also easy to diagnose. If it is early PIE or going for BPD, so what we should do is take the X-ray in your camera without flash. Set that background should be clear white. It should not be dirty. Take X-ray. I mean, take the shot. Then enlarge in your mobile. When you enlarge, you can see more better. When you are, please everybody, whoever there, when you see, come to the right side. Come to the right side. See lower lobe near the costophrenic angle. Costophrenic angle is good. Everybody is seeing. Costophrenic angle is good when you enlarge. Just come like that. As you come to the mediastinum side, you can see white. It is called reticular. It is not, sorry, it is granular, round thing. You can see. It has not become, even if you little more enlarge, you can see even granular pattern with reticular pattern. That means air it has come out from the alveoli. It is passing as well as the pulmonary sheet. You can see like a reticulogranular round instead of white, what I am talking. Black thing. So that is one easy way to diagnose early PIE in your mobile. If you are not able to look into the X-ray, because X-ray is, if the technician is reduce the size, or if your X-ray quality is only CR. CR means computer radiography if you don't have DR. Okay, this is a better way to diagnose PIE. PIE, you know, there are 3 stages, 4 stages are there. BPD also so many stages, I mean 3 or 4 stages are there. That's how you can diagnose with using the technology. Okay, number 1. Sir, is there any ultrasound role for pneumothorax? Ajay.
Yes, sir. Pneumothorax picks up, the ultrasound picks up pneumothorax very well, sir. I just presented there
Yes,
are
sir.
4 ways of picking up, sir.
Yes, sir. So I think so. People know that this is from Muthu,
Yes.
Muthu Selvan from Tamil Nadu.
Yes, sir.
So he has already put it. Ultrasound is having a role. You can diagnose.
Yes, sir.
So thank you, sir. Dr. Anita. Anita.
Yes, sir.
Yes, Anita.
Sir.
Very nice, excellent, charming, and more than that, energetic. Okay, very good. And for you, one question: is there any role in a meconium aspiration with a PPHN together or individual steroids? Because there are some articles are telling about that. The question is full stop. That's all.
Dr. Anita, can you hear? Dr. Anita? I think.
Thank you, sir. Thank you.
Yeah. Can you hear? Please.
Thanks a lot.
Yeah. Anita.
Did you get the question?
Anita, have you
Sorry,
got
sir.
the
Can you
question?
please repeat the question? Sir, can you please repeat the question,
Sorry,
sir? I couldn't hear it correct.
In meconium aspiration or
Yes, sir.
with meconium aspiration PPHN, is there any role of steroids? Because some articles are telling we can use it as in the first line itself. What is your experience?
Yes, sir. So with whatever limited experience that I have had, I have not used steroids extensively in these babies. We have used it very sparingly where there is evidence of lung inflammation which is predominating over the other pathophysiology mechanisms. So based on that, I would say steroids are not routinely recommended for a baby with meconium aspiration syndrome. And as far as possible, we try to refrain from using steroids in meconium aspiration syndrome babies. This is not a routine recommendation at all. We need to try other modes of probably respiratory support before we can actually think of steroids. Because if we are able to provide adequate ventilation, that should take care of most of the things. We have to think of steroids only when we have exhausted all the other options and when we feel that lung inflammation or chemical pneumonitis is taking an upper hand and the management is refractory to other modes of treatment. So this is something that has to be kept as a spare end. This is not to be used to begin with. So steroids, right now the evidence is it is not routinely recommended and it is not used in cases of meconium aspiration. As far as it is when I believe near neonatologists rather to tell about their experience in using steroids.
Anita?
Thank you, sir.
Yeah. Anita, yes, it is the thing what even I used to practice, Anita. Even I used to practice till the, what is that, our Ramachandran, you know that our Indian doctor who stays in America, and Lakshmi Narasimhan is an Indian person who stays in there, and whatever your articles or pictures are there in your presentation, in that all the articles, the first line what they say is meconium aspiration with PPHN, definitely inflammation will be there. That will cause most problem. In that he uses the steroids in 5 all is 2018, 19, 20 till April. He says the steroids should be used in all the Lakshmi Narasimhan and whatever the pictures are there in that articles, it is there. So I was shocked, but I started using with meconium with the PPHN together. but I found more better, comfortable things. But in a lower dose for only short 3 days. Okay, number one. So is there anything perinatally you can prevent meconium aspiration? Perinatally you can advise your gynecologist. How can I, what he's telling, perinatally how you can prevent meconium aspiration to the fetus? That's all question. It is from AP Vijayawada.
Yes, 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 sir. Thank you for the question, sir. Basically, I made a slide, showed a slide on that, wherein it has been tried that it has been shown that elective induction of labor by 41 weeks of gestational age can prevent meconium aspiration syndrome to some extent because it reduces the incidence of meconium staining of amniotic fluid. We have evidence of chronic uteroplacental insufficiency, like in cases of PIH, can go a long way in preventing MSAF. And also there are certain things called as amnio infusion. They have been shown to be beneficial in a mother who has got severe oligohydramnios and also has evidence of fetal distress, wherein infusing some extra amount of some saline into the uterine cavity can bring down the stress on the cord. The cord compression can be relieved and the fetus gets relaxed. So that was the only indication. But when put into a research setting, that did not show any good results and it is not being routinely practiced. And another thing, as I mentioned, was endoscopic suctioning of meconium from the uterine cavity was tried. Again, it is a risky procedure and is not to be ventured for. So there is some aspect of prevention. Like if we are able to give a good ANC to a mother, and if we are able to electively induct a labor by 41 weeks of gestation, we can prevent meconium aspiration syndrome to some extent. Yes.
Yes. One more question. So this is the last. This is from Karnataka only. Why meconium aspiration babies will have more E. coli infection? Why? Is there like that? Even I don't know. Meconium aspiration babies usually will have sepsis, means if it will develop E. coli. Why? Is there iatrogenic or what is this?
Yes. Yes, sir. As far as the literature search is concerned, meconium is a very good culture media for gram-negative bacilli, but I do not know exactly which organism predominates. If that is your observation in your unit, please make sure that it is not because of meconium alone. There may be other risk factors as well. But if we are regularly seeing E. coli in meconium aspiration syndrome babies, probably it is worth publishing if you feel that it is exclusively due to meconium. So probably, and it may be a totally new part of research, it may be a new study altogether if we can prove it. But definitely meconium is a very good culture media for any gram-negative bacilli. So that's what the literature has confirmed already. And if you are coming up with something like a specific organism, it would be even better, and you can go ahead and study even the antibiotic sensitivity. That is right.
Yeah, nice. So, Dr. Prashant?
Sir, yes, sir, yes, sir.
Yes. So, Dr. Prashant, I think so. All my questions are over. Ajay is excellent. So, Dr. Anita is very good. And moderator is God. I don't have any words to tell him. He is God. Okay. And I am handing over the mic to you, Prashant. And please explain about tomorrow class and what is going on. And anything you want to add, Prashant? Anybody wants to raise the hands and ask the questions? Please.
Dr. Naresh
Yes,
Prasad has raised the hand.
yes.
Dr.
Can I
Naresh
ask?
Prasad, over to
Can I
you.
ask? Yes. So, does a high flow can lead to the air leak syndrome? And if the answer is yes, then what should be the cutoff level of the air pressure and the oxygen in such situation to avoid these problems? Shall I repeat, sir? Does use of the high flow can lead to the air leak? And if the answer is yes, then what should be the cutoff level of the air pressure and oxygen to avoid such problems?
So usually we switch over to high flow ventilation. Just high. You're talking about high flow.
Yes, yes. Air pressure and oxygen is only there in this machine.
So, could you please repeat the question, sir? You're talking about high flow.
Machine is there. Anything with the air pressure and oxygen only. And what should be the cutoff level in the case of the air pressure and oxygen to avoid the air leaks by the use of this machine? Do we come across or not?
So I don't have really. Dinaka, sir, would you like to take this question, sir?
Yes, sir.
Shall I repeat, sir?
Yes,
Yeah.
sir.
Please repeat the question slowly and loudly, sir.
We are frequently using high flow machines and
High flow ventilation, sir. High flow
High flow
means high frequency, sir.
high flow machines are there. We comprise of only two things: air pressure and oxygen. So they are the two parameters which monitor. So does this occasionally cause air leak?
He's asking, does high flow nasal cannula does it cause pneumothorax is what he's asking of that. Unable to unmute. Yeah, Dr. Ajay, you can take up if. One second.
He's talking about high flow nasal cannula, sir.
Pneumothorax.
Pneumothorax can, if pneumothorax can occur spontaneously, it can occur with any kind of pressure too. We usually tend to stick to the normal high flow range. Anything, there is no particular level as such. Any high flow can cause. It depends on the fragility of the lung also. Anything else you would like to add,
Okay.
Dr. Dinakar or Prashant or ANITA?
Yeah, one second.
Yes, can I add on to the answer, sir?
Please go ahead. Trying to
Yes,
unmute.
whenever there is air leak and when we are trying to associate with the high flow in a baby, whatever the air flow or the oxygen flow that I give to the baby, it's not the flow alone that is going to decide whether a baby is going to develop air leak. It also depends upon the tensile strength of the lung tissue in relation to the flow that I am giving to the baby and whether the baby can sustain it with good chest compliance. So all these factors together are going to matter. So whenever I'm giving high flow, be it a ventilator or an HFNC, we need to make sure that there is adequate chest rise. If I feel that the chest rise is, it is more than what I really require in this baby, then probably I'm giving very high flows to this baby and I may end up with a pneumothorax as very soon in its course. And initially, even in COIM trial, it was shown that CPAP is associated with a very high incidence of pneumothorax. And that is why the delivery room CPAP was discouraged or it was told to be used with caution. But over a period of time, we all have grown comfortable with delivery room CPAP. With the newer machines coming like TPS resuscitator, we are able to even quantify the pressures and hence we are using them. So it is not the high flow or the high pressure alone. It also depends upon the size of the baby, gestation, the tensile strength of the lung, and also the chest compliance that is going to determine whether a baby is going to develop air leak. So whenever we put the baby on high frequency ventilation, it is basically to prevent air leak. So we are giving very low tidal volumes with a very high frequency. So we are trying to reduce the barotrauma to the lung and we are avoiding an air leak. But when an air leak has already happened, high frequency ventilation is just a rescue therapy and it may not be able to help more than a conventional ventilator. So I think I'm somewhere near to the appropriate answer
No,
for that
no.
question.
Anita, you are very near. Hello, Anita, you are very near, not somewhere. And one more thing,
Thank you,
sir. Hello,
Can I
Yeah,
ask
we can
next
hear, sir.
question?
Go ahead.
Prashant.
Yeah, we can hear, sir. Go ahead.
Naresh
can I
Prasad, sir.
Can I ask next question, sir?
So you can hear, sir. It is like
Yes,
this.
sir.
Yes, sir.
Yes, sir.
Naresh Prasad, sir.
Yes,
One
yes,
small, quick answer for quick catching, easy
Yes, sir.
understanding. Be with me, sir. Now, be with my flow. I mean, my whatever I'm talking, please, your thought should flow with my talk. Otherwise, it won't
Yes, sir.
synchronize. See why
Yes,
I
sir.
use the synchronize, why I use my word and your thought, because if high flow nasal cannula, what you told oxygen and flow, you can use it
Yes.
for preventing apnea, because if there is a laryngeal weakness is there, I mean weakness means preterm, tone is less, otherwise excessive secretions, if it is there, high flow nasal cannula will be useful even for the post extubation. But in the meconium aspiration, high flow nasal cannula won't much act, sir. But if you are using the CPAP bubble CPAP, previously
Yes,
what
sir.
we thought when I was studying, so that time they told, that time I think so CPAP was not there. I don't know, sir. Okay. Later in 2000s, so Wong, Wong, who was worked more in the CPAP. So what he was telling is CPAP, you can use more pressure with the oxygen because oxygen will wash out the nitrous, so such that even pneumothorax will come down. But in meconium aspiration, since ball valve mechanism is there, CPAP won't work much because the delta P amplitude will be less, because it is a variable bubble CPAP. The class will come later, sir. But high flow nasal cannula, it won't work, I am telling you, because even if you are working in the periphery, if you are using even poor resourceful settings, it won't work. You are going to increase the pulmonary hypertension. If it is a minimal, it will improve, sir. If it is a moderate to severe, it won't improve. In the meantime, before you refer the case, baby might have gone for severe pulmonary hypertension. So regarding the HFOV, what Dr. Anita was telling, sir, because in HFOV or flow interrupter, high frequency O means oscillation, or high frequency flow interrupter like SLE 6000, high frequency oscillator like a Leone, like what is that Fabina ventilator. Both, what will happen, expiration and inspiration is both are active, means it will push the air and it will suck the air. Since it sucks the air, what happens is, so pneumothorax means it is air trapping is very less. But if you are going to use the high frequency jet ventilator, expiration is passive. But here you are delivering the tidal volume 1 to 2 ml, 1 to 3 ml only, lesser than that. But there the mechanism is different. So in either meconium aspiration or in this thing, high frequency, if it is the conventional ventilator fails, high frequency is better, but only rate should be less, delta P should be more. If it is a pneumothorax, delta P should be less, rate should be really decrease, I mean increase the rate. If it is not volume guarantee, there is all those things, sir. Another before next coming, not this Sunday, not tomorrow, next Sunday you will learn everything about high frequency, non-invasive, CPAP, everything you are going to learn about what today talk they have given, sir. Thank you, sir. Prashant?
Yes, sir.
Sir,
Yes.
yes, sir. My next question. So, what are the sequelae which we come across after the patients who has recovered from the air leak problem?
Ajay?
Air leak syndrome, is, if they are premature babies, they can go on to have BPDs. So, with an air leak, they can have interventional hemorrhages, PVL. Then they can have, later they have neurodevelopmental problems and cerebral palsies. These are the complications of air leaks, short and immediate and long-term complications.
Yes, sir.
Sir, what are the bacteria commonly involved with the neonatal pneumonia lead to the air leak?
Staphylococcus,
Sir,
sir.
your
Staphylococcus.
voice is not clear.
So, what are the bacteria responsible for the neonatal pneumonia leads to the incidence of the air leaks in the newborn?
Staphylococcus, especially in older babies, we see Staphylococcus causing pneumococele, and same way it can cause newborns to Staphylococcus.
Yeah, Ajay is right. Staphylococcus. At the same time, if it is very negative infection, usually necrotizing pneumonitis, Klebsiella or Pseudomonas. But usually Staphylococcus is the main. Bullous we do see in the pediatric side more, sir. Yes, sir. Any other things, sir?
Yes, yes.
Boliye,
Yeah.
sir.
Shall I ask?
Yeah, yeah,
Sir.
please go ahead, sir.
Am I audible?
Yes, yes, yes.
Yes, sir.
Sir, should we discourage the the stomach wash in cases of meconium aspiration? And what should be the importance should be given to the green staining of the
Anita.
umbilical cord? Green staining of the umbilical cord.
Yes, sir. The slide that I had shown, it has been shown that the studies which were included in that, all of them did nasogastric aspiration of from the stomach. Sorry, all of them can definitely reduce the feed intolerance by 30%. But the only thing was they could not reduce the secondary mass, and the effect could not be seen in the study. But as a practice, we all do it. And it's not always that we follow evidence-based medicine into practice, and we do not wait for the evidence to give us answers for every single question that we have. So till we have the final word on it, I think at least I personally continue to do nasogastric aspiration till I see a clear gastric fluid, because it has shown at least the feed intolerance can be brought down to 30%. Though I may not be totally right in answering this, but in the like I can say with scarce literature, this is what the maximum answer that can give you right now.
No, Dr. Anita, you are very correct. Meconium is a irritant to the stomach. It should be, meconium should stay in the descending colon or transverse colon or ascending colon. It should not be there in the stomach. So meconium is a definitely irritant because it is containing bile. Yes or no?
Yes, sir.
Anita. So it
Yes,
should
sir.
not be there. Stomach wash, what you are telling, what you told is 100% correct answer. Any meconium aspiration, if you will give minimum at least 2-3 times even stomach wash, aspirate everything, keep NPO and OGT free drainage, it is more good, more good.
Yes, sir.
Okay, Prashant, is
Yeah,
there
Dr.
over?
Naresh. Yeah,
Dr.
Dr.
Sir.
Naresh.
One question more. How much importance should be given to the green staining of the? Shall I ask?
Yeah, yeah,
What
please.
importance should be given to the umbilical cord stained green in the cases of meconium for the diagnosis of meconium aspiration when the history is not proper about it?
Yes, sir. We do depend on a lot of surrogate markers to diagnose meconium aspiration syndrome,
Anita,
especially when we do not. Sorry, sir. Hello.
Anita, it is for you question.
Yes, sir. So the question was like, when there is meconium staining of the umbilical cord, and how do we rely upon all the other features to diagnose meconium aspiration syndrome when we do not have a typical clinical picture? So when we do not have a typical chest radiograph, as I mentioned, meconium aspiration syndrome is a spectrum of manifestations. It need not always present with the typical chest X-ray and the typical respiratory distress. Though baby may be born with meconium staining of amniotic fluid, and mother may be staying in another hospital, and we don't know what has happened with the meconium and the amniotic fluid. So we do depend on certain surrogate markers, and we do take clues even from staining of the baby's body over umbilicus or over the skin, over the nails, to diagnose meconium aspiration syndrome if we feel that baby has features of PPHN. So though the chest radiograph may appear like a black PPHN to begin with, later on we may see that meconium migrates to the distal parts of the lungs, and the X-ray may evolve over 3 days. And as Guru Prasad sir always says, the PPHN associated with Meconium Aspiration syndrome always peaks by 72 hours of age. So if a baby is surviving on day 4, day 5 with PPHN and mass, it's always a good sign. So we do make use of the surrogate markers like staining of other parts of the body with meconium while diagnosing Meconium Aspiration syndrome, though the triad does not include these surrogate markers. Yes, sir.
Thank you all. Thanks all of you to make me a participant in this webinar. Thank you all.
Naresh Prasad sir, you have to tell all the sir, you are from West Bengal, right?
No, I am from Dhanbad, Jharkhand.
Jharkhand, sir, you should
Yes.
spread tell everybody like this Karnataka chapter, people are doing every alternate days. You know
Yes,
that
yes.
alternate days
Yes.
they're doing the program. Everybody should participate. Tell in your all state people, sir.
Okay.
Put in the group also, sir. All the best, sir. Over to Prashant.
Okay, thank you. Thank you.
Yeah, thank you very much for a wonderful session. It is, I mean, I'm getting a lot of feedback from all over the country and even from outside the country. Thank you very much for being part of this. So we have the next talk that is tomorrow on respiratory physiology, neonate and non-invasive ventilatory method by Dr. Shiv Shankar and Srinivas, which are projected now, which have shared the screen now. Thank you very much. And this complete 2 weeks, the coming next 2 weeks, it's going to be on neonatal respiratory chapter. We are trying to cover the most of the things. So, it's indeed pleasure. So we'll meet you again tomorrow, same time at 5. So please be there. Thank you.
Thank you. Thank you, sir. Thank you, Anita. Thank you, Ajay.
Thank you. Thank you, sir.
Gurugale, thank you, Vijay, sir.
Thank you, sir.
Thank you.